Hello, hello. So can we start? Okay, thank you very much. So good afternoon to everyone. I'm Dr. Lokesh from Lupin Medical Affairs team. I welcome you all to today's fellow course named FCC-Upgradio 2024. This fellow course is organized in collaboration between Cardiovascular Research Foundation, TCT USA, and PAC Foundation. This scientific program has been supported by Lupin Limited. Before we proceed further, I would like to start the event with an auspicious note. For that, I would like to call today's faculties for the lamp lightning. First, I would like to call Dr. Srinivas Kumar. So please join for lamp lightning. Dr. Vijay Teran, Dr. Chabi Satyapati, Dr. KMK Reddy, Dr. Dilip Kumar, Dr. Manish Kapoor, Dr. Sandeep Mishra, and Mr. Rohit Monroe from Lupin. So please join for lamp lightning. Thank you very much, everyone. Now I request Mr. Rohit Monroe, Vice President, Cardiology Cluster. Now I request Mr. Rohit Monroe, Vice President, Cardiology Cluster, to share his thoughts.
Very good evening. I'm Rohit Monroe, Cluster Head for Lupin. On behalf of entire team Lupin, let me have this privilege to welcome all speakers, delegates, and on the top, Dr. Srinivas. First of all, my thanks to Dr. Srinivas because we do understand he was quite busy. Just a month back, he has completed his conference, that is TCT, but just after that, my team was after him to plan this program. And thank you, sir, for your wholehearted support, helping us to craft such a beautiful academic feast for all young cardiologists. I will just take a couple of slides just to give you the overview of what Lupin is all about. Lupin is being founded by Dr. Deshbandhu Gupta. What did you say? So Lupin is being founded in 1968 by Dr. Deshbandhu Gupta. Dr. Gupta was a visionary with a compelling mission to create a better world for people. Lupin today is having a global presence. Lupin is 2.5 billion US dollar company. Not only that, we are having EBIT of 475 US billion dollar. We are having 15 manufacturing sites and 7 R&D sites across the world. Lupin today is the third largest in US in terms of prescriptions, and we are 7th ranked company in India. Lupin is 8th largest company in South Africa in terms of prescription. We are 4th largest company in Australia and 2nd largest company in the Philippines in branded generics. Lupin is frontliner in innovation in the Indian market. We are having partnership with over 15 pharma companies, including global pharmaceuticals companies like Lilly, Boehringer, Minarni, Novartis, and Vifor, and so on. If you will say Lupin in India, as I said, it's the 7th ranked company. We are having a CAGR of 10%, and we are having strong presence in therapy like cardiovascular, diabetes, as well as in respiratory, which contribute 60% of Lupin India business. Not only that, we are going stronger in other therapy areas like GI, gynae, and others. So I want to say my heartiest thanks to all of you cardiologists sitting here, because today Lupin is the third largest cardiology company in India. We are established our Lupin cardiology in 2000, and today we are having 12 business units in cardiovascular as well as in metabolic space with 4,500 Lupinites, which is the largest number of feet on ground in Indian pharma. Not only that, we are running couple of patient support program. We are having 2 programs which is running at present. One is JEET, which is for our cardiology patient, as well as Hamrai, which is for our diabetes patient. The whole objective to give diagnostic support, diet counseling, lifestyle guidance, and complementary medications to the patients. Both are directed towards education, awareness, as well as adherence. Not only that, 2 years back, we entered in a diagnostic market, and Lupin today is having 47 labs pan-India, and out of that, 50% of our labs are NABL accredited. We are having more than 1,100 plus action centers. I'm happy to announce recently Lupin Diagnostic has been awarded the Best Pathology Lab Award from ET Healthcare Awards. We are also come out with another innovative business, that is Lupin Digital Health. The whole objective is to provide remote cardiac rehab made accessible and affordable to cardiology patients, specialized care pathway for post-PTCA, heart failure, CABG, and CAD patients. This is the India's first CDSCO licensed software as a medical device, and we are giving 24/7 monitoring and emergency care with FDA-approved devices. Lupin keep on getting rewards and recognition from various organizations. Recently, our CEO, Mrs. Vinita Gupta, has been awarded the 50 Most Powerful Women Award in Business. Our women healthcare program, which is our Nova Shakti, has recently got the Patient-Centric Award Not only that, even our Hamrai, the patient support program which we are running in for our diabetes patient recently got the award. So on and so on. So again, this is all about Lupin. So again, I want to thanks to all of you for your active participation that you are going to do, and thanks to all delegates, speakers, as well as to Dr. A. Srinivas. With this, I will request Dr. Lokesh Kumar to take the things forward.
Yeah, Mr. Rohit, please stay back. Before we hand over the session to today's chair, Dr. Srinivas Kumar, I would like to introduce sir. Sir is a senior consultant cardiologist, director cardiology and clinical research, Apollo Hospitals, Jubilee Hills. Chairman, PACS Professional Services, founder, director, and CEO of PACS, which stands for Fraternity of Advanced Cardiovascular Techniques and Solutions. Founder and course director, Advanced Cardiovascular Solutions, India. Founding course director, TCT India. He has a rich experience in research and has been principal investigator and co-investigator in many national as well as in global clinical trials. So I would like to invite Dr. Srinivas Kumar on stage. And I would like to request Mr. Rohit Mandro to please felicitate Dr. Srinivas. With this, I would like to hand over the session to Dr. Srinivas Kumar. Over to you, sir.
Yeah, good afternoon, friends, and thank you, Lupin, for bringing all of us together. It was, we are very fortunate to have a company like Lupin who has such sort of ideas of encouraging education, training, and not only in all sorts of platforms, even for younger doctors. So we do that advanced program, TCT India, and then probably for fellows course, we wanted to design this way. And what I was surprised to see was all was full before the right time started. This is very unusual for our country. Generally, we have starting inertia, but it's planned so that I thank all of you, all the doctors who joined on time. And it was also my wish and desire to do some program with Dr. Vijay Trehan and other seniors from medical colleges, because we always feel a lot of teaching training happens there. And I have Dr. K.M.K. Reddy sir, Dr. Chabi madam, and others who have joined, Dr. Pranab Jyoti Bhattacharya and others. Thank you all the faculty. And we designed this course mostly keeping some basics initially, then probably basics of angiography, and then how to do then the cath lab material designing, then about stents. Then we'll have little go more about imaging, and then probably have our important keynote guest lecture coming from USA from Dr. Ramesh Dagupati and calcific lesion approaches. And then complications is the one which all of us are worried. So we should all learn from others' complications, mistakes, and then that's how we've designed that. And then in the evening, obviously, Lupin has some interest in these newer molecules coming, like inclisiran and probably evabrad and other things. We will have pre-dinner symposia. And we also called as angio fire chart session. If any of you have any interesting angios you want to discuss with faculty, we have a good opportunity to interact. And tomorrow, we will have sessions on CTO, and then Dr. Megha Prasad, Columbia University faculty, will be joining. And then structural heart interventions, and then finally neuro interventions will be discussed tomorrow. This will be the flow of the agenda of the events. And with this, I think now I request Dr. Vijay Trehan sir, a very senior cardiologist, all of us know, many of you must have learned lessons from him. I was also one of them. So we'll have this first session as basics on something to do with angio, cath lab materials, and stents. With this, I request Dr. Trehan sir to say a few words and welcome the first speaker onto the podium.
Thank you, Dr. Srinivas. I think without wasting time, let us invite the first speaker, Dr. Reddy, and he'll be talking about one of very important issues, because most of the diagnostics starts with angiograms, lever-side interventions. So he'll try to give us some tips and tricks as to how to do an angiogram. I think let me not discuss about things. Let him just come out with the tips, and in between we can discuss. And I think I'll encourage the audience, in case you have any questions, you can note down the question, we can deliberate on the issue, and I'll request Dr. Reddy to be relatively brief and leave some time for discussion.
Yeah.
Actually, this course is intended like that. We want it to be more of interactive rather than only didactic question talks. So please feel free to ask, raise any questions, stop in between also. Okay, sir.
Good afternoon, everyone. Respected chairpersons, organizers. I thank the Lupin and the organizers to give me this opportunity. Okay. I think, okay. We all know the angiography is the basic test, but also know that basic test can go wrong, basic test can be improved, basic test should be performed very accurately since it is a basic test. Based on the basic test, many things evolve, revolve. That is the reason why I think it is an appropriate juncture for us to understand what exactly is the technique, or is there any really sharpening things that can be discussed, or is there really any tips and tricks to understand this basic test called coronary angiography. See, the goal of any test is to diagnose the disease, even the coronary angiography. The goal of a coronary angiography is to define the coronary anatomy and characterize the severity of all the stenosis accurately in two orthogonal views. Each and every part of this statement is very important to understand what exactly is the coronary angiography. It should be optimal. That is very, very important thing we need to understand. I'll come to that, why it is optimal, what should be, how it should be made optimal. The optimal should be, it should be something like an excellent, a marvelous, or you can say a first class, most desirable, or at least a satisfactory. So once we do this test, we should be able to understand what exactly is the coronary anatomy. There should not be any disputes about this. That is something called getting an optimal visualization of coronary tree. So, but is it always in our hands? Most of the times it is in our hands, even though we are not able to dictate each and every component. It is determined by the position of the patient on the table. It is also determined by the coronary anatomy itself, the catheters that are available with us. There may be many constraints sometimes. The limitations of the X-ray system or the cath lab, what we are using, is also a determinant for this. And optimal projections used. This is very, very important, because just like that, routinely doing a conventional views and taking a conventional angiography is not the complete optimal diagnostic test we are expected to have. So acquiring the angiographic image, what are the frame rates, how to take it, and the recording and sorting out the digital image system, and how we are displaying it and analyzing it. These are the various things that are interlinked and determining the coronary angiography, friends. So considering the preparation of the patient, is it really important? Before the procedure, what are the things we need to understand, and how to get an axis, what is an ideal axis, what are the hardware, and during the procedure, how to behave, how to take an optimal things also there. I am not going to the details of that. So we know that the indications, risks involved, the contraindications, the cost effectiveness, all these things we need to inform the patients well in advance with a clear language in an understandable way. This is very important, because afterwards, if something goes wrong or goes away from the expectations of the patient, definitely we will be in soup. Everything has to be informed well, clearly. There is nothing like a murmuring or a slurring of the some complication. We have to tell everything white and black, probably if required. Probably 2-3 people also can be involved in the counseling. Very important, not only to save our skin, to have a ethical practice techniques. So some of the techniques I'll try to understand. See, a high quality imaging, for anything, including the coronary angiography, that at least a digital flat panel technology is the most commonly used technology to get an optimal views and optimal angiography. And a broad knowledge of the catheters, mandatory. See, there is a saying by my teacher saying that if we don't have a knowledge about either the drug or the catheter, we have no business to use it. It is 100% correct. And that is the reason why we need to understand why we are using this catheter. Is it really a good catheter for this patient? We need to understand. Delivering an adequate amount of radiographic contrast, friends, very, very important. What is the, see, most of the textbooks say some amount of like 6 to 8 ml for the left system and 5 to 6 millimeter, 6 to ml for the right corner system. Is it always true? No. For example, if there is a non-dominant small right coronary, where do we inject 5 to 6 ml? In the same way, if there is a very ectatic, large left side vessels, probably we need to inject more than the expected. It is an average components that are there. But for this, we need to understand what exactly is the situation, or is it the coaxial, or is the leaking back. There are many things that are there. So the C-arm in the cath lab and the fluoro, cine, we need to know all these things. What are the advantages of using cine, when to use cine, when to not to use cine, when to use only fluoro, all these things. And there are certain techniques called a collimation and a filtration. This is to understand probably the area of interest has to be focused, and improving the image spatial resolution and limiting the radiation dose. This is another thing that is coming up very widely these days, how to protect ourselves in a way of protecting the community. Very important. It is something like we need not be like a lighted candle in our life. So the breath holding sometimes, yes. Increase the frame rate, yet sometimes it should be used. And increase the catheter size. Very important. We need to use the catheter size. Suppose if there is a small lumen of a vessel, we need to change the catheter, downsize the catheter size and try to do it. And vasodilator use, yes. If there is a spasm of some component of the vessel, we need to use the vasodilator like an NTG and try to redo the procedure and optimizing the heart rate. Very important. We can't go on taking the patient for a heart rate of 120, 130 and go on doing whatever we like. It is being happened rampantly, but the ideal way is if there is a heart rate high more than what they expect, and we need to use a different technique like a high volume of the contrast to be used, and it becomes sometimes a toxic dosage also, and coaxial of the system. So I am not going to these details of the LAO, all those things, but moving the image intensifier, I think before I just say this image intensifier, this is the image intensifier is the determinant to say what is the view. It is not the X-ray source. So the goal is to view the arterial segment in its most direct angle. Very important is, see how the given segment of the vessel or the given vessel is directed, we have to see directly in an orthogonal view with the least angle projection effect. That is very, very important. So rule number 1 is, if the LCX goes with the image intensifier and the LED goes in the opposite direction. This is the basic rule. In other words, moving the image intensifier leftward in the LAO projection, it will project the LCX to the left on the screen and the LED in the right. These are the basic rules. And the cranial angulation is always useful, will elevate the LCX up and pull down the LED. It is reverse in the caudal angulation. The same rule is applied to the diaphragm and the spine. The rule number 2 is to straighten the very tortuous vessel, the image intensifier should be moved to an angle more or less 90 degrees opposite to the present one. It's a very, very important technique. So these are the standard views. Probably most of us will take the LAO-caudal, epicaudal, RAO-caudal, or sometimes we'll skip the epicaudal, come to the epicranial, then RAO-cranial, LAO-cranial. Probably some people choose only 4 views, but generally these are the views that are standard views. So what is this orthogonal view? So involving the right angles at right angles, very, very important to understand the orthogonal views. Until unless the orthogonal views are taken, we cannot decide exactly the severity and anatomy of the coronary artery. So it is something like, I'll give some examples. LAO45 orthogonal to RAO45, LAO45 and caudal 45 orthogonal to RAO45 and caudal 45, so on and so forth, like that. So until unless we visualize the coronary anatomy in an orthogonal views, we may go wrong in assessing the severity or the extent of the lesion. So there are certain pictures I have taken, like how to understand the left main coronary artery and the segment wise. Ostial, what is the ideal view? Like LAO 50 and caudal 20 is for an ostium, and the shaft is PA caudal. So in correlation, I have shown certain pictures. I know it takes a lot of time, that is the reason. See, so see the shaded area is to understand the mid segment. If we want to see the mid segment of the LAD, the mid segment of the LAD, I think these are the projections like LAO 40 and the cranial 30 we have to see. In the same way, if you want to see the distal part of the things, you have to go with a RAO 40 and the cranial 30. It looks silly that probably is it really required to see under all these things? It is required. It is required. It is something called a focusing on an area of interest. If you want to see, suppose if there is a doubtful lesion at some part of the vessel like a distal LAD, and what is the view to be seen? That is very, very important. And same way for the main views for the other vessels also I have mentioned. Invariably, we have to concentrate on all these things. If there is a normal coronaries, but before we say something like a normal coronaries, we need to see the entire vessels of the entire coronary tree before we say it is a normal. So for that, we need to understand how we missed a small lesion, a ring-like lesion at some part of the vessel is always important. So same thing, the bifurcation lesions. See, the angle that is involved, the extent that is involved, we need to predefine before we intervene and explain about the situation to the patient. We need to understand, assess these things very importantly. And the graphs, see, this is also very important. Suppose if a lemma to LAD has to be seen, we need to see the exact views like a left lateral or the straight PA. These are the views that should be done to understand this. Same thing, a venous graft to PDA and probably to even to the OM. These are the common grafts that are being given. We need to see this before we hand over to our surgical colleague. But everything is done, but we always tell what are the pitfalls, what are the limitations of our study. We always should mind this because there is nothing like one procedure or one test is an ultimate on this earth. We need to understand the pitfalls where we can go wrong. It is a luminogram, evaluation of the three-dimensional structures. That is something called two-dimensional view of a three-dimensional structure is the limitation. I know I had to run. Let me use some technique.
You have only 40 seconds.
Yeah. Yes, sir. See, the causes of a lumen narrowing other than the atherosclerosis, we need to understand. And unlike the CT-CAG, the angiogram doesn't permit the visualization of the vessel to demonstrate the atherosclerosis. The degree of coronary stenosis is usually a visual estimation of the percentage of the diameter. So here certain deceiving views, a proximal LCX, there are certain I'll just go to some of the important things. Oversizing, undersizing also is important. Two views in case of a left main disease is very, very important. A steep cranial angulation is the view that results in the most radiation exposure to the operator. And unable to engage a coronary ostium, yes, it can happen. And there are certain tips that can be used as a left coronary artery, usually clockwise from a radial and counterclockwise from the femoral, a separate origin, LCX clockwise rotation, the LAD counterclockwise rotation, and catheter below the ostium, above the ostium has to be either decreasing size or increasing the size. And the right coronary, also there are certain things, and I'll give rapidly certain examples. A selective engagement into the LCX streaming in LAD is the first picture. The OM2 lesion, ostial lesion, was missed on the caudal view, but was evident in the elevocranial view where the vessel was elongated in the orthogonal views. So these are certain examples where we have missed. Not engaged coaxially is the first view, and the myocardial bridging is the another one.
Dr. Reddy, I might just stop you here. Can you just play the previous one? Just the previous one, the film which you played.
You want to see this, sir?
Previous one. Okay, let them just play.
This one?
Yeah.
Yeah.
Now just focus the top left. Is it an optimal angiogram? See, you are gone there, taken a catheter there, you also have a dye with you. You are injecting the dye. You want to accomplish the procedure safely, but you also want to come out with information. See what is wrong, which is happening in the top left. The moment you inject, your catheter is recoiling back. It's kind of a whiplash.
Yes.
So I wanted to learn as to, for the youngsters, yes, if this kind of an angiogram is done, if I walk into the cath lab, I'll tell him a lousy angiogram.
Yes,
useless.
That is the reason why it is taken as a not engaged coaxially.
So what are your tips for this kind of an angiogram to be
so
corrected?
with this, we need to understand what is the reason for this non-engagement. Is it the size or the disease of the proximal segment of the left main? Here, inappropriately, the diagnostic catheter is sitting there. It is not taking the support and sitting there. It is trying to something like a hooking there and coming out. So the moment we give a contrast, it is coming back. So probably either the position the catheter, rotate into the coronary ostium, or change the catheter so that it gives a support from the...
Actually, this is a function of the push with which you push the dye inside the catheter.
Yeah.
If you have a flimsy catheter, let's say a 5 French catheter, you have a catheter which is not strong enough, and you want to inject the dye with force, what will happen? You'll have a whiplash. Newton ka teesra law. The moment you push the dye with force, you must have seen gardeners gardening with pipe. The moment there is a jet of water coming, the catheter will have a recoil. So it's a function of force with which you are injecting. Also, the function of how strong or how much weight the catheter is having. If the catheter is having a higher weight, it has a less chance to recoil. Thirdly, what is the lumen size? So if, let us say, instead of this, it was a bigger catheter, wider lumen, bigger catheter will have a higher inertia, less chances of recoil. And if the lumen is wide, it will not create a big jet effect. But many times, you cannot change the a diagnostic catheter to a guiding catheter. Then what to do?
Yes. Yes.
What is
so
your take?
here actually it is the Judkin's left was used. Probably the proper size was not taken.
So one of very simple trick, which I've been doing for last nearly 4 decades. If it is a diagnostic catheter, just take it out. Take a puncture needle, make some side holes into it. Now the moment you shoot the dye, your recoil is not in a direction which is coaxial with the catheter. You are injecting dye like a pigtail catheter. You see, if you have pigtail almost never recoils. And it doesn't recoil because you have holes all around 360 degree. So if you just create 2 holes near the tip, just try to make it like a multi-purpose or a Sohn's catheter, that this business will go off.
Yeah. But see, I agree with you. But here, actually, the moment we see a scenario like this, it is there is a discordance of the size. That is, it is not supporting
No,
well.
I just wanted to make the session interactive because it was going more didactic.
I know.
Now, one of very important problems in angiography, which I call is a suboptimal angiography, is you have done an angiogram, you find a disease, you have sent a patient for surgery, patient undergoes surgery, and following surgery, the patient is again symptomatic. And then after the symptoms, the patient is now reluctant to undergo angiography. Patient undergoes a CT angiography, and CT angiography tells everything is normal. Have you understood the story? You did an angiogram, and you found a disease. Patient was sent for surgery. Surgery was done. Following surgery, patient starts having symptoms again. This time the patient is taken up not for a conventional angiography, but for a CT angiography, and a CT angiography shows no disease and block grafts. This is commonly seen in a suboptimal angiogram when your catheter tries to, this catheter would have possibly also irritated the LMOS. If your catheter irritates the LMOS, you can falsely make a diagnosis of left main ostial disease, which most of us are not very happy or keen to do a left main angioplasty. So we'll be happily sending these patients for surgery. So if you are doing an angiogram and if you find a disease close to the catheter tip, all of us know it happens on the right side. All of us know. And all of us know that we should treat this area with vasodilators. But remember, if it is happening on the left also you can have a significant vasospasm. So your angiogram will be suboptimal. If you have done angiogram on the left side and you find a tight lesion close to the os of the left main, which is close to the catheter, and you have just finished the angiogram like this, this LM os should be treated with tons of vasodilators unless you have created a significant hypotension with drugs which can produce hypertension like nitroglycerin and all, or bradycardia with drugs like adenosine or with the diltiazem. I think you should not stop. Keep giving the dose. The doses given in the books are sometimes not applicable to individual. So you can give 100 mics, 100 mics, 100 mics. Let's say diltiazem, I commonly give 5,000 micrograms. And many cases I have seen 200, 300, 400 mics has done nothing, but 2,000 micrograms leads to dilatation of the LMOS. So remember, your left angiogram is suboptimal if you reported a disease at the os without treating it with tons of vasodilators.
Yeah. See, if you see the right top is a typical example of a spasm. This is exactly where the situation will.
I think in the interest of time we can, because we still have to discuss lot many things.
Yes,
and,
sir. I'll just go to one last slide, sir. Dear friends, the take-home message in this are, the angiography should be aimed at quantifying the severity of stenosis with the latest radiation, with the least radiation and a minimal use of contrast. The lesion encountered has to be quantified in 2 orthogonal views. Always review all the angiography pictures or views for an assessment and take further views if necessary before leaving the lab. That's very, very important. You have to take the complete loop, study there on the table, and if there are any additional views are required, then and there you have to take before you end the patient. And it is always to be kept in mind that it is an invasive diagnostic test. Means to say, we cannot go on repeating this. A poor angiogram is of no use in diagnosing whether the patient has CAD or not. Thank you.
Dr. Reddy, one question. As already mentioned by him, that while doing an angiography, it is of utmost importance that we give only limited amount of contrast, because contrast nephropathy is a very common thing. So what is your single tip to the fellows to decrease the quantum of contrast?
See, basically we need to understand immediately when you take, like most of the times, as I was telling you, the left main disease, if you rule out a left main disease, it is easy to know in the AP caudal or max AP cranial. If we do that, there is no point in reassessing, taking more views. Some people go with a conventional view, like as I was mentioning, 6 views. All 6 views are not required. Suppose the AP cranial we have taken, there is no LAD disease. Why to take a RAO cranial again?
That's okay, but many times we lose a lot of contrast in just finding an artery. What happens for the fellows? They'll take a catheter, attached to it to a two-way board or to a three-way adapter, and the pressure line is going on. And they are making a maneuvers with the catheter, and they are trying to look for the diving movement of the catheter in the right coronary artery in the LAO view, and the left coronary they can do in the LAO in the PA or RAO, whichever. What they look for a diving movement. After that, the first step which is done is that you push some contrast and see whether you have hooked or not. According to me, you can most of the time avoid this, because many times you must have seen you're giving contrast, dikhi nahi, phir diya contrast, phir nahi dikhi, phir diya contrast, phir nahi dikhi, ghumaya, phir nahi dikhi. And what is happening is you have wasted kind of 15, 20, 30 ml contrast. So what I'll suggest is, because all those fellows who are given a catheter to do an angiogram, I think they have already seen hundreds of angiograms before that. Watch very carefully what is happening to the catheter tip when your senior is doing it. And you must memorize as to in which view, where the catheter moves, in most of the cases, of course. With that movement, you will know that most likely it has hooked. Now what is required is don't shoot a contrast. Take a 10 ml saline in your syringe and shoot it. If it is into the coronary artery, you will suddenly find changes in the ECG on the monitor lead. The changes in the ECG are typically in the form of ST segment going down, T getting inverted, sometimes the R wave going up, and QRS getting widened. Same changes which you see during treadmill. They will be there on the monitor lead. Second thing is, you can inject the contrast with force, and that will also tell you whether your catheter is going to have a whiplash or not. In case your catheter is going to have a whiplash, it is wrong to shoot dye, waste dye, and come out and then create holes. If you are shooting and every time you find your catheter is having a whiplash, take it out, cut some holes on the side, take it in, shoot some saline. If with saline you find ECG changes are taking place and the catheter tip is stable, I think this is the time now you can take contrast in. And of course, if on the first shot you find two arteries are totally occluded and you are not in the habit of doing CTOs, then I think your business should be to just show where is a distal vessel. And for showing a distal vessel, when you're giving left injections, you should be looking for a right which is filling retrogradely. And when you're doing a right injection, you should be looking for the left which is filling retrogradely. And you should inject a contrast and keep your foot on the foot pedal on the cine, continue to do cine till the time you find retrograde filling of the distal vessel, because this is what you want to show to the surgeon. For a surgeon, the angiogram is different. For a cardiologist, the angiogram is different.
Yes.
Thank you very much.
Yes, sir.
Thank you, Dr.
Reddy.
To join us. I think the idea what sir was mentioning is basically you need to have a mentally picture of all the coronary arteries, all its divisions and branches, and you take shots till you image all the aspects of the coronaries, right from ostium to mid-level to distal, and the same thing with all the three. And once you get a picture, then you can stop. You need not continuously take more and more views, but generally LAO-cranial shows LAO left main ostium first, the contralateral view RAO caudal is taken, then probably more information. Idea is to get entire information. Only problem comes in angiogram, once you go out, patient goes out, then you can't. That's what Dr. Reddy was telling. You have to have a complete information before you send the patient out. Otherwise, catheters are designed to go into it. Very rarely, as what they're shown could happen, but by and large, it is reasonably okay. Sometimes, other problem which Sir was mentioning was, especially in radials, streaming of dye happens, and left main disease which is not there also appears sometimes because of streaming, and that could be another fallacy, especially when you're doing radial procedures. I think there are more things which can happen. Some of you might have some doubts regarding the assessment of stenosis, eccentric stenosis, and like that we can have some discussion on how to assess those lesions later. I think we can invite...
In the meantime, any question from the audience? Any specific problem somebody wants to ask?
I think all of you...
And if there is none, then I think I'll request Dr. Satpathy, because I think we have finished with the angiogram. Now we have business of entering into the vessel from the angle of treatment, which is done starting with a guide, then with a wire, and then the balloons.
So before ma'am can start the talk, I would like to request Dr. Reddy. Sir, please stay back. Sir, Dr. Reddy.
Dr. Reddy?
Sir, please stay back. So I request Mr. Rohit Mandro to please come on stage to felicitate Dr. Reddy. big round of applause, please. Thank you very much, everyone. Over to Madam for the next talk.
Very good afternoon to all the fellow members who are present in this hall. Now I'll be restricting my presentation to only balloons because for 15 minutes I think it will be inadequate if I cover all the three. I'll be only talking on balloons. Now I'll be talking on compliant and semi-compliant balloons, the non-compliant balloons, the high pressure and the cutting balloons, scoring balloons, something about the chocolate balloons, drug-coated, IVL, perfusion and ostial flash balloons. Now as we know, the balloon catheter has various parts, like it has a tip, it has a shaft, it has two markers, and it has a hub. So these are the parts of a balloon we must be very familiar with. And we have two different types of balloon catheter. One is the over-the-wear balloon catheter, another is a rapid exchange. The difference is this is a double barrel till the end. It's a bigger catheter, the wear comes out at the end. And this one is a double barrel just at the tip for 30-40 centimeters, and the wear comes out at the exit port, and the catheter is relatively smaller. Now, what are the basic difference? What is the advantage and disadvantage of this? Now, if you take one over-the-wear balloon, the distal wear position is quite stable. You can take multiple wears, which is accepted with this, and the contrast and drugs can be infused through the hub. However, you require two people because where when you are taking outer in, one people will not suffice for this, and the catheter diameter is usually bigger. Now, when we take a rapid exchange balloon, it's ease of use. A single one can do in the lab. You may not require another operator, and it's a smaller catheter, but it requires more of support. The wears cannot be easily exchanged, and you have a blood loss. Now, what is the basic structure of a balloon? The balloon has a working length. What is a working length? From the marker to marker is the working length that touches the tissue when you inflate. When you inflate, this much length only touches the tissue. And we have a cone angle and a tapering length. The cone angle decides the tapering length. If the cone angle is more obtuse, the tapering length becomes smaller, and the reverse. If the cone angle is more acute, the tapering length becomes bigger. I'll come to the use of that. Now coming to the semi-compliant and compliant balloons, the semi-compliant balloons, once you inflate, the volume increases with pressure. So wherever is the resistance, it goes on inflating at the other places. Now non-compliant with your pressure, the rigidity increases, the volume and diameter doesn't increase much. So the dog boning is more with the semi-compliant balloon versus that of the non-compliant balloon. So what happens when the pressure is increasing? In the non-compliant balloon, the size does not increase much. However, in the compliant balloon, it increases proportionate to your pressure. So where is the least resistant, it goes on increasing with more of dissection. Now this dog boning effect is more common. Size increases with pressure and offers a good rewrap. You can increasingly use multiple times. But here with the pressure, your atmosphere, the rigidity it increases. It's more important for the calcified lesions, and you cannot reuse a non-compliant balloon. Now next is the dedicated pot balloons available at few centers we do not have. Now what is the advantage here? Because the angle of the cone is more obtuse, the length of the tapering balloon is shorter, we are more appropriately placing the marker close to the site of interest. Now, this is the tapering length of a conventional balloon versus that of a dedicated pot balloon. Because this length is smaller because of more obtuse angle, the marker placement is more accurate with your interest. Now, this is a high pressure balloon. Now, it can go up to like 40-50 atmosphere without increasing much in size. So, it's more, dog boning is virtually absent in these patients, though less of data is available for these. So, whenever you are requiring a high atmospheric pressure which is not yielding to a conventional NC balloon, you can take a high pressure OPN balloon. Now, this is almost like equivalent with a scoring balloon. The study says of 2021. Now, conventionally, we are using some semi-compliant balloon for pre-dilatation. We are putting a stent there, followed by we are using NC balloon. Now, this study shows that in patients when we are dilating with high pressure balloons, NC or OPN balloons, pre-dilating, followed by post-dilating with NC balloons, the result is much better. It is quite safe also. We do always hesitate to pre-dilate with some NC or OPN balloons, but the study shows that the result is better and it is quite safer also. Now coming to plate modification balloons. Now this is a cutting balloon. Now this has some mounted lengthwise some atherotomes or microsurgical blades of height of 125 micrometer and width of 100 to 400 micrometers. Now this actually is a high profile balloon, NC balloon, so it may require, while you are doing, you may require a body wear or could be a wiggle wear to avoid that wear bias or could be a guide extension. But always remember the inflation and deflation has to be slower and has to maintain at the end. So this is the result of a patient who showed a large calcific nodule here, and this with a cutting balloon, the appearance is a little better and the area is also bigger. Now with scoring balloons that wear either a single or multiple, either it is integrated into one side of the balloon or three wears are spirally wound around the balloon, or the recent grip TT shows multiple nubs, 3 to 4 rows of nubs across the length of the balloon. So these three are commonly available for modification of the lesion. Now, what is the difference of scoring versus that of cutting? The cutting balloon is usually a non-compliant balloon and this is a semi-compliant balloon. This is a low pressure inflation balloon. It requires relatively high pressure. We have some micro blades or atherotomes. We have nitinol wear wounded around. Data is more limited for these cutting balloons. We have enough for, we have more data for the cutting balloons and limited for the scoring balloons. And the cutting balloons are bulkier. The crossing profile is higher, so difficult to deliver compared to the scoring balloon with a lesser profile, easier to deliver. Now this balloon is a chocolate balloon where there is nitinol wear wrapping, multiple circular wrappings around the balloon lengthwise so as to form pillows and groups. So pillows, they put localized pressure, and the groups, they act as stressors, they act as stress relievers. So whatever is pushed will come to the groups, so the dissection propagation will be limited. This may be drug coated, may not be drug coated. Now coming to the advantages of these balloons, the modification balloons, they are non-slip balloons. They grip onto the lesion. They do not have a watermelon seeding effect causing trauma to the proximal or distal part of the lesion. It reduces trauma thus to the healthy tissue. It has a focused pressure. It grips and gives a focused pressure at low inflation, causing less of micro incisions or scoring, and exposes the elastic lamina and less of barotrauma, so less of neointimal proliferation or restenosis, but useful for difficult lesions like instant restenosis, mild to moderate calcification below 180 degree or ostial or bifurcation lesion. Now this is about the IVL balloon. We have three components. One is a portable, important is a portable and battery rechargeable with a connector cable and the balloon. Now what is done? It's a novel tool for modification of the calcified lesions with acoustic pressure. Now here, once the electrical energy is given, the emitters inside the balloon, they give electrical energy which vaporizes the fluid inside the balloon to form spheres. Now these spheres, they generate expanding bubbles once vaporized, and they come across the tissue at a pressure of around 50 atmosphere, at a pressure of 50 atmosphere. However, you have to inflate it at low pressure of 4 atmosphere, and the balloon matrix is limited. The disadvantage, we do not have beyond 4 or do not have a length of beyond 14. It delivers 10 pulses at a sequence to a maximum of 80 from the emitters. So it doesn't cause barotrauma to the vessel wall. It enters into a depth. So both the superficial and the deeper calcium can be affected without affecting the healthy tissue. It has a differentiation capacity to affect only the calcific tissue, and we have to dilate a little up to 6. before deflating the balloon. Now it shows that the technology of modification is easier to use than any other atherectomy devices and associated with low procedural complications. Now it has a short learning curve compared to others like Eurota or this is a short learning curve, easily adopted, do not have a wear bias. So it doesn't have ruts and troughs across the lesion, and the debris embolization of the debris is too less compared to the other atherectomy devices, and the thermal injury is less because the emitters are not touching the vessel wall and the vascular complications are too less. However, we may have known other terms subtopics. With emission of energy, you can have a ventricular capture with some arrhythmia, but they are not sustained and do not cause any adverse effect. So this is how IVL balloon is having a calcium rupture. Now, what are the disadvantages? It has a larger profile. So it may or may not enter into a lesion, unlike Eurota where this is going on. So limited size matrix, we do not have multiple sizes. It has a limited pulses per catheter, so it is quite costly to afford for. And it do not have effect on eccentric nodular calcification because the energy reaches circumferentially across the vessel wall, more favorable for circumferential calcification, and we do not have more of long-term clinical outcome. So drug-coated balloon, now this is SC balloon. This is SC balloon with a matrix on the balloon which is having two components. One is the active drug which is a lipophilic, and hydrophilic is the spessor or known as the excipient which helps release and dissolving the drug. Now it limits the area where we are doing. We are finally doing a pre-dilatation. Wherever is the pre-dilatation, the drug-coated balloon has to cover proximal distal through millimeter beyond. Now apart from instant restenosis, which is already class 1A, it's also useful for small vessels and bifurcation. We must remember it should be delivered to the lesion within 2 minutes of entering the human body. Otherwise, we are losing the drug with a single inflation time of around 60 seconds, and then this should cover 2 to 3 millimeters of both sides of the pre-dilatation so as to not miss the geographic missing should not be there. We have different types of coating methods, could be a spraying, could be dipped inside, could be a micropipetting or nanoparticles on or drug imprinting. Now, thus depends the efficacy of the balloon. Now, what they are saying that if you are having a pre-dilatation, you see whether it's acceptable for a DEB or not. If we have a no flow limiting dissections beyond 3, no residual stenosis beyond 30%, and if you are doing beyond 8, then only DCB can be applied. Otherwise, you are bound to go for a stent. So, advantages of this is that shorter duration of DAPT, unlike 1 year, you may also go for 1 to 3 months, particularly in patients with high bleeding risk. The anti-proliferative drugs are delivered without leaving any permanent prosthesis or a durable polymer, enables performance of bypass surgery in a patient who is too young. You can put a surgery bypass onto that lesion if you have a DEB versus that of a stent. The vasomotion is intact. The luminal gain which occurs late, that is preserved with a DCB versus that of DS. If with a DS, the patient has a late lumen gain, there will be a stent malapposition. There is no metal allergy or strut fracturing, and delivery of the drugs onto the vessel wall is uniform. In contrast to the struts in between, it's a balloon. So continuously uniform delivery of balloons onto the lesion, and there's no uncovering of struts or durable polymers, no stent thrombosis. So this is almost like leave nothing behind, like your bioresorbable scaffold. So this is what the difference between the two drug-coated balloons, what is paclitaxel, what is sirolimus, how to choose, which one I'll take. So paclitaxel has more of a robust evidence by now. The drug is a taxane class versus that of a Lehman class. It is irreversibly bound. The paclitaxel is irreversibly bound, absorb very quickly and persist in the tissue for a longer time because it has a crystalline coating. Versus that of sirolimus, it has a reversible binding, absorbs slowly, and quickly the concentration comes down because it has an amorphous coating. Now coming to perfusion balloon, unlike the other balloons, a dedicated device to allow distal perfusion through a prolonged inflation, you have distal perfusion along with it because equipped with multiple holes proximally as well as distally. Suppose it's a perforation, you want to dilate it for minimum of like 1 minute, 2 minutes. Perfusion balloon is safer because the distal ischemia is not occurring. It can compress the thrombus and rupture plaque for a long duration. You can infuse drugs also through that, and is reassured in perforation and LM crossover stentings. So this is how the distal perforation is maintained when you are taking a perfusion balloon versus when you are taking a conventional, there's a distal ischemia. Now it says that the components MACE is also significantly lower versus that of conventional balloon, and the secondary endpoints of no reflow ST elevation arrhythmia is much lesser because you do not have distal ischemia. Now this is a flash ostial balloon. It's a double balloon, one distal balloon which is non-compliant, other proximal balloon which is compliant. Now this is required when you are having ostial stenosis or out ostial stenosis. First you dilate the distal balloon, then you dilate this. So the proximal struts of the balloon are opposed onto the ostial wall across a 360 degrees. You are not leaving any tissue there for a restenosis. So these are the hubs. One is for the proximal balloon, one is for the distal balloon. So this is how it opens up 360 degree versus what we conventionally do. It is still not opposing onto the vessel wall. The proximal compliant balloon of 14 millimeter opposes all the struts 360 degrees across the ostium. So these are the complications. I think I should stop it there. Thank you.
Thank you, madam. I think you can join here. Yeah, because of paucity of time, madam, we couldn't cover guides and wires and other things, but we can have some discussion. But what generally doctors would like to know is, suppose you have a difficult lesion, difficult to cross. What is the balloon of your choice, sir?
I think this is a very important question. Like, let's say you have been able to cross either a total occlusion or a very tight lesion, and now you want to take a balloon there, and the balloon is not going. And in fact, one of the treatments for uncrossable balloon is resorting to other methodologies, which is like rotational atherectomy. But a lot of people, when they present their case and show that this was a balloon uncrossable lesion, many of us will say, well, we could have easily crossed it. So this is what is a question which is given to me by Dr. Srinivas, that if there is apparently balloon uncrossable lesion, so what should we do as far as selection of balloon is concerned? Well, first is the quality of balloon. You should try and have a quality of balloon, like you have many local balloons which are kind of okay for a routine lesion, but for a real tight calcified lesion, especially distal lesion, it is better to have a quality of balloon which is well tested, like balloons from Termo as well as from Boston and from some of the reputed companies. They perform better than some of the balloons which are relatively cost effective. Second is a balloon which is smaller in length will be easier to cross than a balloon which is longer in length. However, any balloon has a marker. A short balloon will have a single marker, and a longer balloon will have two markers. And marker is a place where the shaft of the balloon becomes thicker, because there is a shaft. On the shaft you put a marker, and then comes a balloon surface. So if you have to use, if the lesion is uncrossable, then it is preferable to have those balloons which are swaged markers. The markers which are embedded onto the shaft, they are not projecting up. So this is number 2 when it's a balloon uncrossable lesion. 3 is taking a support guiding catheter. Of course, you can take a guide extension, take it as close to the lesion, and then try to take the same balloon deep down. But the third is many times a ninja technique. If you take the balloon close to the lesion and then go with a jerk. If you go with a jerk, same thing which was not crossing will be able to cross that lesion. So I think the tips are that in case it is a balloon uncrossable lesion, take a guide which should be supportive. If the guide is supporting, take a guide extension which can support you. Take the guide extension as close to the lesion as possible. Take a newer balloon, take a compliant balloon, take a balloon which is longer in length, shorter in length, sorry. Take a balloon which is smallest in diameter. However, it is the second problem might start that this balloon crosses but does not dilate. I think that
that we'll discuss. But I think as sir mentioned, Rinjan balloon of Charmo, I think 1 into 6 mm balloon has come now. That is the easiest balloon to cross because of single marker and it's low profile, it goes better. And each of you could have your own preferences, but that is the balloon of choice. But you have to analyze why the balloon is not crossing, whether it is a support problem, whether it's the wires off, not being support, or the guide problem, all that also as sir mentioned. But if you have to have one balloon shelf on shelf, probably that is the best balloon. And probably compliant balloons are better initially to go. Non-compliant balloons are more stiffer. It doesn't cross immediately. Once you make some channel, some lumen with regular this type of balloon, then you can take high pressure balloon and NC balloons and dilate more. I think Dr. Ramesh is waiting because he had to leave for some other talk. He is ready. Madam, you want to say anything before we go on to Dr.
One thing I want to say, answer. So which of the balloons that the markers are not on the shaft and embedded inside the shaft so that the caliber will be less?
Like if you look at Abbott technology, Abbott technology came with the stage markers about 15 years ago. All Abbott balloons have a stage markers. The markers are embedded. That's how, even if the coating of the Abbott balloons is not as good as will be Termo balloons and Boston balloons, still an Abbott balloon might be able to cross a lesion because of the stage markers. And it is always preferable to have a single marker balloon than a 2 marker balloon, because in a 2 marker balloon, the marker is at the end. So if the marker is at the end, the balloon will not be able to even enter. A single marker balloon, some part of the balloon will go.
Half of the balloon is gone.
Half of the balloon will cross. And half of the balloon which has crossed is ready to at least dilate the lesion partially. And if it dilates the lesion partially, then you can gradually walk into the lesion. So it is better to have a marker away from the tip. And that will be with a single marker.
Nose aiding technique it is called. As you put the nose.
One question to you, I think, which is probably relevant to all of you.
Yeah, I think we'll have more discussion, but Dr. Ramesh Dagupati sir, who is supposed to talk on calcium and this approach is something relevant with the balloon non-crossable lesions. We requested him to be there, and as always a good friend, always being ready in spite of his busy schedule, he has to have go to some other meeting, but still he obliged us. Thank you, Dr. Thank you, Dr. Ramesh. I have Dr. Vijay Trehan sir and Dr. Chabi madam with me. We can see you, and thanks for your time again. And we're waiting. Hall is full here. About 350 doctors have come in personally, and then all of us are eager to hear to you. And Dr. Trehan sir wants to say a few words to you before you go on to your talk.
No, I just wanted to welcome him.
Okay. Always a good friend, always being ready in spite of his busy schedule. He has to have go to some.
Good day, everyone. Can you hear me? Dr. Srinivas Kumar, Dr. Trehan, and Dr. Chabi. Are you able to hear me?
Thanks for your time again. I think you can start.
So I'll go ahead and start. I know you're running short of time. So I've been given the task of talking on approach to calcified lesions. I have no disclosures for this talk. So I think the most important part I want to also make sure that everyone understands is that whenever we're trying to do interventions, we have to be very cautious in stable ischemic heart disease, because these are the patients that we have to follow some algorithmic approach and try maximal medical therapy, including nitrates, beta blockers, calcium channel blockers, and ranolazine. And if all of that fails, only then actually consider revascularization to improve symptoms. So just because they have a complex lesion doesn't mean that we should intervene, our calcified lesion, we should intervene on them. So which lesions are complex lesions? I think as we have discussed, ma'am wonderfully alluded to this. Distal left main, non-left main bifurcations, long lesions, small vessels, drug-eluting stent, in-stent restenosis, calcified lesions come under that as well, and chronic total occlusions. Eclipse is a trial that actually is going to be looking at evaluation of Can you hear me, or sorry? Reason. So Eclipse is a clinical trial which will let us know whether our conventional angioplasty strategy is going to be equivalent or not, and we have to wait for the results for this trial still. And so this is an interesting trial, about 2,000 patients in 60 United States trials, and looking at the OA strategy with a balloon angioplasty. I think we are not, naive to calcified lesions. Even the second patient of Andreas Kronzig was heavily calcified, and it was 70% stenosis in the LAD that was unsuccessful for PCI or PTCA in those days. So we know. Can you hear me, Dr. Srinivas Kumar? Because it says the host is muting me. I don't know why. And I'm trying to unmute myself, but it again, automatically the host is muting me, it says, okay. Can you hear me? Hello? 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 Are you able to hear me? Okay. The host is muting me, it says, and that's what I'm. Okay. Okay. There's a lot of echo still, but hopefully you can hear me. So I wanted to talk about approach to calcified lesions, and I said that be careful before we tackle these calcified lesions. Many of them are probably stable ischemic heart disease, and we may not have to do anything if the medical therapy works, and only if medical therapy fails and the patient continues to have recurrent angina, then we should tackle with PCI. So which lesions are complex lesions? Calcified lesions also come under complex lesions in addition to all the other ones that are listed on this slide, which are left main, non-left main bifurcations, long, small vessels, drug-eluting stent, instant restenosis, chronic total occlusions as well. So as I was saying, that ECLIPSE is a trial that actually is going to look at different treatment strategies, which is orbital atherectomy versus conventional angioplasty prior to implantation of drug-eluting stents in 2,000 patients. And this is an important trial which will let us know whether a atherectomy strategy has any role or any benefit, superiority over conventional balloon angioplasty. And unfortunately, this trial was designed before IVL was there, so we have to still probably do another study looking at IVL versus atherectomy strategy. But so even Andreas Kronzig's second patient had a calcified lesion, and we know the calcium can yield to unsuccessful results as one was in his case. He could not perform a PTCA because of the severe calcification. And sometimes angiography alone may not be able to give us the calcifications very evidently. And of course, if you see one side of the vessel calcification and versus two side of the vessel calcification, you can say that one is moderate, the other one is severe. If you see a train track of calcification on both sides of the vessel wall, that alone in angiography may not be enough because we only pick up about 38% of the patients as calcified lesions, whereas if you see imaging, it plays a role to pick up severity as well as how bad the calcification is in those patients. The coronary calcification is a predictor of a worse prognosis, as you know, death, MI, and any revascularization. All of them are worse than the red with the severely calcified lesions. And whenever you try to do a balloon in these people, they actually, as the ma'am said, the dog boning effect, and you can have dissections, and that can cause more complications. And inadequate stent expansion, as you are not able to completely dilate the lesion, and preventing drug delivery, and also stent delivery at this point of time. So a simplified strategy for calcified lesions are mild. If you see angiographic calcification, mild, moderate, severe. If it is severe, like a train track appearance, and it is very tight lesion, even the luminal narrowing, so go directly for atherectomy strategy. In this patient, there is probably luminal and calcification that actually is in support of the adventitial calcification as well. And whereas mild non-atherectomy strategies such as a balloon would be enough. And in moderate, you probably have to do a balloon testing, then intravascular ultrasound, and then decide whether you have to follow the atherectomy strategy. There is much more complex algorithmic approach that you see. Balloon crossability is what Dr. Trehan was saying earlier. If you can't cross with a balloon, then you try different types of balloons that are available from different vendors now, which are nano balloon or small 1.0 balloon or 0.9 balloon, and try to gradually increase the balloon sizes and able to open it up. But intravascular ultrasound after pre-dilation will help us to decide again the strategy whether it should be lithoplasty balloon or orbital atherectomy, and whether in those people who the lesions are not yielding well. But if you cannot cross with a balloon, there are only a couple of things that you can do. Can you cross with a microcatheter? And if you can cross with a microcatheter, probably you can also try laser here and after direct wiring. And if you cannot even wire the lesion with the orbital wire or the rotor wire or a Viper wire, laser is a very good strategy in those patients where you cannot get anything across. But if you can get a rotor wire, and then I think our orbital Viper wire, I think atherectomy is a very good strategy, followed still by either conventional or angioplasty balloons, including Wolverine or other cuttings balloons, or actually lithoplasty balloon. So I think this has been covered. High pressure balloons are very good. We just started using that. I have a very good experience with them, OPN balloons, which came to US much later than India. And but most of the time we resort out to rotablation or orbital atherectomy in heavily calcified lesions, in addition to using other adjunctive techniques such as angiosculpt, Wolverines, and shockwave, or even laser. So here is a patient who had an OPN, in this patient after stent under expansion and not able to dilate it with conventional balloon. With a high degree OPN balloon, we were able to, a high pressure OPN balloon, we were able to get a great results in those patients. Okay. So how about the rotablation and cutting balloon? Sometimes you have to rotor these type of lesions where you're not able to get a good stent expansion. And we'll talk about the rotational atherectomy in a little bit in a short period of time. But following that, you can do pre-dilation and with a 3O NC balloon, and still the lesion could not be successfully expanded. And as you see, the circumferential calcific ring limits the expansion of the balloon. So we might have to do further either rotational atherectomy or actually maybe another dilation with a Wolverine balloon at a 3O with the 26 atmospheres, and it finally yielded. As you see, there's a waist here and there's no waist here, so the lesion can be completely expanded. And following which, the next step would be much easier. As you can see, there are cuts of Wolverine as well after the cutting balloon cracks to the calcium. So I think this is a great strategy that you can see, and after stenting, the final picture looks really great with that. So I think ma'am talked about dog boning effect of a NC balloon, and even if you keep going high pressure, what you are risking is actually a risk of edge dissections. And better than that is actually using a Wolverine balloon, which actually helps us to uniform expansion and less risk of edge dissections. Let's look at laser. I mean, for me, laser actually is a very limited use. If I cannot get anything across, just a wire is able to go and nothing else, and then only I put the laser. But that said, in instant restenosis, there is a role for laser. And so this is a patient with instant restenosis of the LAD, and index PCI was done with the rotor and the DK crush stenting. And pre-procedural intravascular ultrasound shows that the stent is still not well expanded, and there is some whether instant or even calcium behind the laser. So you can do two things. If the calcium behind the laser, behind the stent, you have to use a shockwave or IVL balloon. But if there is any instant restenosis and calcified or fibrotic lesion, probably those are the places where laser might work. The more calcified it is, the laser has a limited results, limited success. I think if it is more fibrotic, then laser definitely has a role, and you can give here 60 pulses and 80 or then you can actually try to see. Even you can deliver with contrast that is much more powerful. laser. While doing lasing, you can puff contrast through the guide catheter. And so that yields much better results, and the stent is now widely open, and LED diagonal stent look great. And you can see that the results in the IVUS actually shows there is some cracks to the calcium when you use contrast with the laser. So the next, I think, is the shockwave balloon. This has become the commonest thing in the United States now because, as ma'am said, many of us are worried about complications from rotational atherectomy or orbital atherectomy. So we have, I'm in charge of about 10 centers, and all our other 9 centers did get IVL balloon first because they do not have surgical backup, and rather than sending to primarily all the patients for atherectomy to our center, I said, let's get IVL balloon. In this heavily calcified LED diagonal lesions, you can see severely calcified lesions that are going to come here. And you can see that this is all heavily calcified now and concentric and very tight. So in this type of diffuse and severely calcified lesions with more than 180-degree arc of calcium and OCT lesion preparation with a direct shockwave. So how I do it in my practice is I deliver an NC compliant balloon, non-compliant balloon. If the NC balloon can go, then you can deliver a shockwave balloon. If the non-compliant balloon doesn't go, then actually stop. That there's no way that an IVL balloon, it is expensive, don't open it. So if I'm planning to do actually the way that I actually do a shockwave balloon is size it distal to vessel reference diameter. Say, for example, it is 3.5 millimeters. Maybe go with 3.5 millimeters and go to 4 atmospheres and then deliver the pulses. And then finally dilate to 6 and come down. So I try to keep it actually 0.8 to 1 to 1. So either 0.8 or 1 to 1 is the sizing that I actually do. Some people probably do undersizing with IVL. I do not recommend that. So after doing a shockwave in this patient and getting excellent results and delivering now we can deliver up to 120 pulses using a coronary balloon. Previously it was 80. And you can see that actually that vessel expands quite well. And there are cracks in the calcium. There's some dissection as well. There's some here cracks again. And multiple cracks are visualized, as you can see, in all these places and expansion. So once you do that, actually, you can do more pre-dilations if appropriate with an NC compliant, non-compliant balloon. And then probably you can look at the angiogram and finally decide on the based on IVUS what size stent you want. And so this is the final result of that LED that actually was treated with the shockwave balloon. And so in the OCT pullback, it actually shows well-expanded stent, and the minimal stent area is definitely greater than 7 millimeters square. So another heavily calcified LED diagonal, this is much more calcified than the one that you saw previously. I don't think that anything else would work here, such as an NC balloon or actually a IVL balloon. And so we sorted out for a Viper wire, and then actually you can see orbital atherectomy. You have to move it very slowly, 1 millimeter per second, and then you are able to advance this very nicely and over time. So orbital atherectomy actually rotates at 80,000 to 120,000 RPM. We usually go 80,000 in the LAD. And since this is a complex bifurcation, treated diagonal first, as the flow was limited in that, the slow flow was noted. And so stented a provisional stent strategy with the LAD, and just left the diagonal ostium the way it is, even though it looks slightly bad. But the TIMI3 flow is observed. So our aim was only to treat the LAD here. And then the patient actually had started having chest pain. And so we had to change it to a two-stent strategy. So bailout tap technique and a modified tap technique for this LAD diagonal bifurcation. So then you have these type of patients who will come to you once in a while, where in-stent restenosis heavily calcified and they're not actually opening up with an NC balloon on how much ever you try at the 3.0 NC at the 25 atmospheres. What do you do in that? So normally it is off-label using anything atherectomy strategy. In this, IVL probably could have been used, but this is pre-IVL era for us in the United States. So we went with orbital atherectomy. As you can see, the stent is actually slightly crushed in that area, not opening up. And after orbital atherectomy and NNC balloon, we were able to open up that stent quite well. And this is pre, and in the post, it looks like that. So there is a role for these patients, but be cautious. It makes a lot of noise. Instant lesion preparation with an orbital or rotor is off-label. I want to make sure everyone understands, and only experienced stands, I think we should be using those type of devices. So optimal lesion preparation might be including rotor, laser with contrast injection only for underexpanded stents, or Wolverine or angiosculpt at very high pressure. OPN it's been very great for me, and lithoplasty or lithotripsy shockwave balloons are actually, as you know, the success is really great. And one of our cardiology colleagues now became the chief medical officer, Nick West now, and orbital atherectomy still has a great role. So in our algorithmic approach, uncrossable lesions, I think in our center, we quickly go to atherectomy strategy because we are going to be wasting a lot of products if you don't choose this upfront. Maybe we can use the 5 balloons and then get an okay result, or actually go to an atherectomy strategy and then get a much better result. So the differences between rotational atherectomy is a high-speed rotating diamond tip burr. It is going to be both front and back in the future, whereas orbital atherectomy right now is both can ablate forward and backwards as well. So the mechanism of action is cutting an abrasion with a rotor. With orbital, it is sanding. And both of them are similar size, 1.25 millimeter burr to start with. Rotational atherectomy can go up to 2.5 burr. The advantage of orbital atherectomy is you can actually do a 6 French radial sheath, a radial guide catheter, and use it for all type of vessels, including left main large vessels as well, with a 1.25 burr. So what are the incidence of pacemakers rates in these people we looked at? And 11.5% in rotational atherectomy versus orbital atherectomy is 3.9%. So it is probably a little bit safer. And when you want to look at when to use which device between the two, larger the vessel, I choose orbital atherectomy. Smaller the vessel, probably rotational atherectomy is good. And the more tortuous the vessel, actually it is, both, I mean, less tortuous, both are effective. And whereas rotational atherectomy, I prefer for more tortuous vessels, as actually it can track better, and you can do that one, I think. But, and finally, very tight concentric calcium. I prefer rotational atherectomy, though I have used both, but I feel that rotational atherectomy gives me much faster and better results, whereas you have to be very patient with orbital atherectomy and do multiple runs. And so osteal lesions, again, orbital atherectomy, you can do both. I actually try to go backwards, advance the orbital atherectomy beyond the lesion and come backwards, and that actually will do much better, and it will prevent ioto-osteal dissections in these patients. And so, but the rotational atherectomy has been what most people used. And one of my colleagues in Long Island looked at both, comparing 273 patients matched analysis, and he felt that the in-hospital mortality is 0% with orbital atherectomy, 2.2% with rotational atherectomy, and Pervez Miraj has done it from North Shore Hospital. So I think all these people are very complex and high risk patients, so we have to be cautious about how to use mechanical circulatory support and balloon, and also wedge catheters or PA catheters will help you to decide what type of therapy should be done in these people, and whether any mechanical circulatory support should be used or not is being tested in Protect 4, which we are happy to say we are one of the enrollers in these patients as well. So assess hemodynamics and select patients based on imaging, get comfortable with simpler calcified lesions first, and prevent complications with proper techniques. And finally, do not rush during calcified lesions. I'll stop here and I'll take any questions. And sorry for the technical difficulties. Can you hear me? Dr. Srinivas?
Ramesh, are you able to listen to us? We are not able to hear you now.
Yeah, I can hear you now, sir.
So,
Yeah.
so in the resource limited environment, you are very much aware about our country. If I look at your opening slides where you said that angiographically we find calcification in small number of cases, about 1/4, and but if we send in an imaging catheter, whether intravascular ultrasound or OCT, then it is found in significant proportion of cases, 2/3 or even 3/4 of the cases. So what my question to you is that in a resource constrained environment, there is no doubt that if you have a significant calcium on fluoro, we know that we'll possibly have to do something beyond a simple balloon. But what about those?
Right.
What about those 3/4 cases which give us not uncommonly unpleasant surprises? Then, if of course, if we send in imaging catheter, then we'll be able to find most of them. We'll be able to kind of preempt most of those unpleasant surprises of huge calcium. But can you give us any tip in the absence of imaging as to how to improve angiographic detection of calcium? Because
yes. Yeah, I know you know the answer, Dr. Trehan. Thank you for asking me. So the most important recommendation and teaching point for all the fellows who are in the audience is that do not actually just look at one view and decide whether you got a lesion preparation. Dr. Trehan has taught all of us.
This is a very important line. All of you should remember. There is absolutely no doubt that imaging is a way to go as far as angioplasty is concerned today, but you will have a limited environment. So you must try your level best that you're trying to image not in one view. And I'll say one step ahead that many of us have cath labs with stent boost. Then once you have a wire across, sometime you can take a low profile balloon there and that can just work as a sensor for you, and then you can start your stent boost there. Many a time a calcium which was not seen will start lighting up if you have a stent boost with a balloon already there.
Right. Absolutely. I think, there has been a study that looked at actually experienced operators may not actually require all the intravascular imaging that we talk about, and it didn't change. So initially, you might depend upon your visual estimation and then confirm that with intravascular ultrasound. But as you become more experienced, you probably know that, hey, this lesion is calcified. And you don't actually have to go with several balloons. You can just take either OPN or IVL, or when resources are limited, probably atherectomy or one of these only you can choose. You can't choose multiple strategies in each and every patient, even though we show these type of cases for live cases or in conferences. But in reality, everyone, including in the United States, we always are looking at how can we cut down the amount of expenditure. So please pay attention to that. I think take two views, both LAO and RAO, and looking at whether the balloon has expanded, use stent boost appropriately. All these cath lab techniques are available with the now good imaging systems in the cath lab. You are able to actually detect the calcium much better with just an X-ray. So maybe zoom in and take a spot X-ray of that vessel and look at how it is. And other thing actually you can do is maybe CT scan is much cheaper. If you really want to, before you bring the patient to the cath lab, you can also look at a CT scan that is done.
Also, Ramesh, what is your take on a relatively sizable vessel, say about 3.5 or 4 millimeter diameter, and significant calcium, but kind of a lesion which probably will not be ablated well with a 1.5 or a 175 rota burr. What I'm saying is, like, if you have a 4 millimeter right coronary artery, huge calcium from os till the crux, and you've already kind of done 1.5 or a 175 bar, and still not able to blow up a balloon there. And now we all know that this is a case for rotatripsy. So my question to you is, that if there is a long segment disease, 4 millimeter vessel, right coronary artery. Now, if we use a standard coronary IVL catheter, then even with the C2 plus, I think the cost is going to be enormous because you'll have to put some 3, 4, or 5 balloons. So what is your experience on a peripheral IVL balloon, which is longer, that is about
Yes.
4 times longer, and has pulses which are at least 3 times more than the pulses which are there in the coronary balloon. So that way we'll be kind of saving 1000% money as far as IVL is concerned. So do you have experience of using a peripheral
Yes.
IVL in coronary, and
Yeah,
give us some tips?
Yes, sure. I actually had the whatever we have to say off-label use of peripheral balloon in the right coronary artery because we did not get the coronary balloons approved at that point of time by FDA. So in this patient, as you mentioned, the 4O, large vessel, and the long RCA lesion, severely calcified, we took a peripheral balloon. So the advantage of the peripheral balloon is it can give 300 pulses instead of 120. And you can actually obviously deliver much better in a large vessel. Sometimes the delivering that might be difficult because of the bulkiness, and using guideliner might be an option. In my patient, we did not have to do any of that, and still I use peripheral balloons in certain areas where the iliacs and peripheral pulmonary veins, stenosis, and these type of calcified lesions. But in the coronaries, obviously, a 4 or 40 millimeter balloon is available that you can use the peripheral balloon that was delivered into the right coronary artery, and I did successfully.
Dr. Ramesh, question from the hall is for the calcium imaging, which modality you prefer, IVUS or OCT? Question from our audience.
Very good. I think if you have the luxury of using both, it depends. I actually still use a 90% probably IVUS, just because our center is mostly, that's how we have contracts, one with one or the other. And the idea is also that many of our patients have renal failure or chronic kidney disease, and so ability to use IVUS is better. But OCT is great. In my previous practice, it was the other way. I used 80% OCT. So it all depends upon the affordability of the patients and everyone.
What is your comfortable also is important for the operator, I think.
Absolutely. Yeah.
Madam,
You should be able to interpret the images very well.
Yeah. Madam, you want to say anything? Okay. Sir, any questions? Any other questions from the hall? Otherwise, Dr. Ramesh has to leave. Thank you, Dr. Ramesh, for your time and
Thank you.
sharing, and a big round of applause. I think a lot of people benefited, and thank you again.
Thank you.
Thanks. I think we'll have a stents talk by Dr. Dilip, and then we'll break. Yeah.
So I would like to request Mr. K.D. Rao to felicitate Madam. With this, we have come to the end of the first session. There is a coffee break. Okay. So we have one more talk.
The talk, yeah, I think Dilip was kind enough to agree to delay his talk, but we'll finish the talk and go for coffee break. Regarding another important aspect which we all know is stents. Stents have revolutionized interventional cardiology, and we wanted to have some idea and the preference of each of the stents, and how to select, and if any particular choices, and then where is the role of new BVS coming up, along with where to avoid stents also. We requested Dr. Dilip to talk on this. I think over to you, Dr. Dilip. Thanks for accommodating this in time and coming here. Thank you.
Yes. So, good evening, everyone, and thanks for the invitation. So what I'm going to talk is, I'll be taking you all through journey of cardiology and how stents evolved and what we are staring at this moment. Some real new developments have happened, have happened in the last couple of years, and I'll be talking on them. So this was the date, 16th of September 1977, when interventional cardiology, practice of cardiology changed forever. And these were the people involved. The Andres Krujik, he was the operator, and Mr. Adolf Patchman, he was the patient on which the first angioplasty was done. And these were the hardwares which were used by through which Dr. Krujik devised his first angioplasty balloon. And this was the result when the first balloon, documented result of first balloon angioplasty was seen. You can see here the proximal LAD lesion after the balloon, and this is 1 year after the ballooning. You can see there is a positive remodeling. The vessel, in fact, grew in the size. So this was what the angioplasty delivered by Dr. Grunjik and the first patient. And in fact, after 40 years again, the angiogram was done. There were some other lesions and it was stented, and the LAD was still flowing well. So this is how the angioplasty started. But the basic problem with the angioplasty was once you do the angioplasty, the operator and the surgeon used to wait for something happening in the night or maybe next day, and there was a sleepless nights because acute vessel closure was 5 to 10% of the cases. So 24 to 48 hours were really vital, and 1/10 of these patients used to have acute vessel closure. And to treat that, then came the stents, and these were bare metal stents to begin with. And you can see here the Cook, CR, and pulmonary skull stent, which were initially available, and these were crimped in the cath lab. I think Dr. Trehan was here. No one better can tell, can describe how angioplasty evolved. So the stents came in, and this was the stent designed by Daughter, and the stents were able to give the good sleep in the night to the operators and the surgeons. But again, half of these patients were coming with angina in 6 months to 9 months. So the restenosis rate was 20–50%. And this was again a problem. And then came the drug-eluting stents. So the first drug-eluting stent was Cypher, and then it was Taxus. Paclitaxel and sirolimus, drugs were used. And they were, eluted on polymer. And these stents were real success, and it was all over the world, the angioplasty with stent. And then gradually the operators and the patient started seeing the good, bad, and ugly of angioplasty with stents, first generation stents. The good is, you can see here after 7 years, 0% late loss. And the bad one, still we were not out with the ISRs. Still it was around 10 to 15% ISR was happening. And finally the ugliest part was the late stent thrombosis. So these stents, which were not allowing the vessel endothelium to cover up, totally in around 9 months to 1 year, sometimes 2 years, they can develop late stent thrombosis. So these were the good, bad, and the ugly part. And then came the second generation stents. And here the everolimus eluting stents came, juterolimus eluting stents came. The polymer was also changed. And these were quite a substantial leap. And you can see here the SPIRIT 2, 3, and 4 and compare trials settled this issue that no, the second generation stents are far better, especially with the paclitaxel eluting stents. The Taxus stent was out. Still the Cypher was being used after these trials. And then there was a competition between the stent makers. So let's make this stent thinner. Let's take away the polymer part. Let's make it a bioabsorbable polymer, or eliminate the polymer forever, or eliminate the stent even. Now there is a kind of drug-eluting balloons are coming. So these are the concepts and in the competitors. So how to divide which stent is thin, which is ultra thin? So there is a criteria which is there. A thick stent we call when the thickness of the struts is more than 100 micrometer. Thin is 70 to 100, and if it is less than 70, this is ultra thin stents. So our Merrill company makes a stent which is 50 micrometer. And we have 60 micrometer of Orsiro. And all other stents which, you use, Zans, Onyx, Synergy, these are something like 6 to 75 millimeter stents. So these are thinner stents, thinner stud stents. And what we see is these contemporary thinner stents, they have got good results. You can see here, meta-analysis of 66 trials, 74,000 patients, roughly, with 60 to 80 micrometers, stud thickness. You can see the results like stent thrombosis is for favoring these stents. Very late stent, obviously, very late stent-related events were lesser with thinner stents, and ultra-thin new bioabsorbable polymer drug-eluting stents were even better. So these were the advantages. So deliverability is easy. So thinner stent, it will go in very quickly. Less thrombogenicity, so less chance of stent thrombosis, better vascular healing, and less footprint. Means if you deploy a stent in the main vessel, side branch access is easier. So what's the problem was less radial force. So I don't think this is quite a problem. We have never encountered such a problem. Even left main, stenting is being done with this. So this was initial apprehension that lesser radial strength and force can be a problem, but not exactly in practical terms. So what was the issue then? Let's get rid of polymers. So polymers, if you are severely calcified lesions, you are putting your stents, inside, scrapping and trying to just push in, your polymer can be damaged, your struts can be damaged, and their elution can be a problem. And so there was a thinking that let's go with a bioabsorbable polymer. But this looks very kind of compelling and very attractive, but the results is not the same. Results clearly shows that still drug-eluting stents with a permanent polymer is better. You can see here, as compared to BMS, these bioabsorbable polymer gives a better result, but as compared to newer stents, everolimus eluting stents, especially fluoropolymers, these are inferior. Not inferior, it's not superior. So there is a very clear, now there is a kind of a settled issue that bioabsorbable polymer doesn't give you an edge. And these are the results. So some of the stents came, still this synergy is a bioabsorbable polymer, but you can see here the EVOLVE-2 target lesion failure at 3 years, PROMIS element versus synergy. Not much of difference, but numerically better, even the PROMIS element was better. So this study finally settled this issue. So there is no kind of extra edge we are going to get when we are using a bioabsorbable polymer. Now finally, polymer-free metallic stents. How can we have a polymer-free metallic stents if we get a drug-coated stents? So drug is directly coated on stents. It is sprayed there. So the advantage could be you can stop your dual antiplatelet earlier, and there is a biofreedom drug-coated stent. And this was, in the LEADERS trial, this was compared with BMS. So we don't have a head-on comparison between a DCS drug-coated stent versus a normal drug-eluting stent. So this is still in kind of infancy stage, and probably the takers are not much. After the biofreedom, none of these stent makers, they are quite upbeat about this, concept. Drug-filled stents are also, there is a concept, there will be a place there inside the stent design where the drugs can be filled in and it will elute without a polymer being there. But these are all a concept and it's not exactly in practice. Finally, we all know the story of bioabsorbable, bioresorbable scaffold, so BRS or BVS. So it looks very exciting that once you put 3 stents in the LAD from top to bottom, and after 3 years, your stent is free, your vessel is free to take another stent, or you can do a bypass surgery, the patient will have vasomotion, and everything is so good. There is a positive remodeling. So BVS came with the concept that the vessel grow outwards. There's a positive remodeling. The stent, once you put a stent, it will remain same, the kind of diameter, or it can little recoil, or there can be ISR, so it will go down or remain same. But when you put a BVS, the vessel can be a positive remodeling. The vessel can look larger after 1 year or 2 years or 3 years. So that was the concept which came, and we all were very excited. So I put so many absorbed stents, and I think thankfully my patients were all doing well, but the results they don't, say so. This is similar. So this is a kind of a 3-year absorb outcome data, and which clearly shows this is inferior to normal drug-eluting stents. So this issue is also settled now. The normal BVS, which is more than, which is 150 millimeter strut thickness, and with a lot of its own, problems, it's not fit at this moment to be used in humans as compared to drug-eluting stents. But our Meris is there. We have been using that. That is 100 micrometer thick, and you never know the thickness was a problem or what was the problem. But we need results to make it a kind of to claim that this is superior to normal drug-eluting stents. So finally, after the stents, what next, and what we are today staring at? So this is there. Is there a sleeping demon out there? Once you put a stent, the stent remains there, and this can cause prolonged inflammation. This can cause again a stent thrombosis after 5 years. There can be restenosis. There can be a lot of problems. So this event rate is not minuscule. 2% each year up to 5 years. So every year, 2% of these patients will develop some big MACE event. So putting a stent, leaving it out there, you can't be relaxed. 10% of patients will have problem in 4 to 5 years because your metallic stent is, still there. So we have drug-eluting balloons which have come up, and I think Dr. Satyavati showed us about the properties of paclitaxel and sirolimus balloons. Sirolimus is not that hydrophilic, so absorption is a problem and retention is a problem. So all the balloons came with paclitaxel balloons, which is hydrophilic, easily absorbed, stays there for maybe 3 weeks, 4 weeks, and then the job is done. And then this is also cytotoxic. The sirolimus is static, and paclitaxel is cytotoxic. So these were the properties, and we have got maximum clinical evidence with paclitaxel eluting balloons. But nowadays, a very novel sirolimus eluting balloon has come up. That is called, the name is solution SLR. And what the claim is, this is not a drug-coated balloon. This is a drug-eluting balloon. So this is not DCB and DEB is different. What they claim, they have a micro-reservoir technology that is called a CAT technology, proprietary cell adherent technology, which ensures that in the micro shields, the drug will be there, and it will elute just like what we see elution in drug-eluting stents. And they claim that at 90 days, till 90 days, there will be drug elution. And they are very, very kind of confident that the results will be far better. And we also feel with the initial first-in-man results of the trial, it looks very attractive. So sirolimus is also coming with a big way, with a drug-eluting balloon, not a DCB. So the concept is a little more attractive and different. So this is the unique proprietary micro-reservoir technology, which elutes the drug gradually for 9 months. And finally, I will show you some cases of how the entire concept is changing. You see here, this was a patient who had a Lima to LAD, which was patent, or SVG to PD, which was patent, and you can see a circumflex, osteoproximal disease, and 2 OMs, almost total occlusion. And what are you going to do with these OMs? So there was only one option for this, to put drug-eluting balloons. So both were ballooned with a portage balloon. This is a paclitaxel eluting balloon. This paclitaxel eluting portage balloon has a advantage that the same balloon you can use 2 or 3 times in the same patient. So 3 lesions treating, you require only one balloon. So 90% efficacy, then 60%. That's still the 30% drug which is relieved in the third inflation, which is good enough, to have a better result. So these lesions we are giving drug-eluting balloon, and final result was this. So I will show you the final result. And so this was the final result, and this was again a case where patient has an inferior volume eye, and where we treated the patient. He was in cardiogenic shock initially, then staged, he came back to us, and you can see the LAD was totally akinetic. Probably viable, non-viability was a little doubtful, so I put a drug-eluting balloon there, and then you can see this diagonal and the LAD The LED took a drug-loading balloon and finally a DES in the proximal segment, and it was kissed, and this was the final result, and the patient is still doing well. So these are the patients where you don't have any answer except DEB. You can see this is a CTO which I opened, and then I appreciated on IVUS that entire LED is diffusely diseased. So after the balloon, entire LED was diseased. So I will take 30 seconds more, and there was no other option than DEB. I left it there, and patient is still doing well. So, so the drug-loading balloons, finally in 30 seconds, I will be giving this idea that we have so many trials in small vessels, bifurcations, calcified lesions, left mains. This meta-analysis, none of these studies have raised an alarm. So everyone has apprehension. What is happening? You put a balloon coming out. There's a dissection there. Still 30%, 20% disease there. But none of these studies has raised an alarm. So it means these are self-limiting. Nothing is going to happen to this patient. They give a positive remodeling. And finally, in conclusion, at this moment, when we see the evolution, we have a stents, but it is exciting to watch the new war of DCB technology. We are probably staring at hybrid method of coronary revascularization, stent plus DEB in distal vessel. And time will tell whether the dominant way would remain the stenting or goes the other way in favor of drug-coated balloons. Thank you so much for the patient hearing.
Thank you, Dr. Dilip. Just join us. I think thanks for covering up all the aspects, right from starting to most latest BVS and then probably stent metal-free technology which we are up to. For the sake of younger generation colleagues, I would throw some questions because they are hesitant to ask questions. On their behalf, I would do that. Okay. So, here any particular stent choice? Obviously, where you have a long diffuse disease, where you feel that you are only doing DEB, that's different. But if you have any particular stent choice, depending upon either patient or particular location, do you feel any stent of preference or anything? All stents are same?
Stents you're asking. So yeah, so I do have a choice of stents. When we, deploy stents in left main, I usually take Megatron stent. That has got a very high radial strength. Second, the side branch access is much better. And when I am doing bifurcations, I take either Nagomi or maybe Onyx Frontier, which has got a very good side branch access. And third option would be Synergy XT. So these are my options. And I also use Merrill Meres. If I see the patient is very young and he has a mid or distal disease, so I don't want to put a stent which is going to be forever with him. So I put Meres there. So these are the way I choose my stents.
I think for osteal locations, I think especially left main ostium, to position it correctly well in using the elevocranial view, probably Xine stent, which has a marker starts at the stent, that is preferable probably for the osteal location. And as I said, for side branch access of cells which have open cell design, like Onyx and all is preference. Do you have any choice in high bleeding risk patients, like patients who are not able to tolerate antiplatelets, where you have to give a short adapt? Do you have any preference for that or anything?
Yeah, so when I am going to use, patient has a more high bleeding risk, and these are not a less number of patients. 1/3 of our patients are HBR patients, and here we have trials with Nagomi stent and Ultimaster. We also have results with Synergy XT, Synergy in fact, not XT, and Onyx 1 trial is there. So all these three stents can be used where we can stop the dual antiplatelet between 1 to 3 months. So there can be abbreviated DAPT if we use these three stents, and these are documented literature. So it's not like we are extrapolating the data. Yeah.
I think if you have high bleeding risk patients, now we are giving less and less duration of dual antiplatelet. And probably after a month, nowadays we're getting away from aspirin and probably giving the more potent one of the antiplatelet drugs. Probably if you're too much worried about the bleeding, you may give clopidogrel. Otherwise, we continue with ticagrelor. And as you said, if there's long diffuse disease, you see in some of these diabetic patients, and what is the concept coming up is metal-free angioplasty PCI, the probably focal tight stenosis, you can use a stent. Yeah. and then probably do drug-eluting balloons. And other important area where DEBs are coming is the difficult to stent scenarios. I think osteal LCX, osteal LAD, where you have a bifurcation, where you have to side branch, all that, the main vessels being stented, and the side branch you give a DEB. Or LCX ostium, which was again difficult for us to conquer. Now we do orbital atherectomy as some part of preparation and deliver the drug there. So those are some of the newer things I think are coming up with the usage of drug-eluting balloons. Other areas is ISRs, when you already have 2 layers of stents, we don't want to put a 3rd layer. First time still I think people prefer doing a DES of other make probably. And then the 3rd time you don't want to use a 3rd metal, that's where I think drug-eluting balloons are strongly preferred. But what is recommended is strong bed preparation and making the lesions better. And what is the cause for ISR which has happened, studying it well with imaging and expanding it would go a long way in preventing again a 3rd problem. So those are some of the newer things coming up. I think he has touched upon different types of stents, somewhere a newer, thinner BVS, and then also about drug-eluting balloon. Any other questions anybody has, or shall we break for coffee? Any questions from the audience? Yeah, can you pass on the mic to madam?
We are doing all LM crossover stenting. Do you have any cutoff, a STROTS beyond which we should not, like it may fracture? Or for example, the radial strength cutoff beyond which we should not give. Do we have some cutoff for LM crossover or LM?
There is no such data. There is no such claim also. But I think the studies which are there with this left main, intervention, in studies there is no such documentation that this stent should be used. As from there is no guidelines also. But these are the makers of company makers, like the companies. They claim that it has got a radial strength more, so it should fit there. So we have been using even Indian stents in left mains, and nothing is happening.
Yeah, we do use,
so there is no such claim.
One apprehension. There's a sudden change in diameter.
No, what is important, madam, is the expansion limit of the stent. You have to keep it in mind. If you are putting a 2.75 because the distal LAD or mid LAD cannot take, you can't expand that to 3.54. Right. So that maximum expansion limit of the stent, which is written on the box, has to be kept in mind. By and large, 3+ stents are okay to go up to 4.25. But if you are taking a 2.5, maximum it cannot go more than there too. Actually, that is, if you expand it, there could be damages to polymer. What all happens, architecture also is not known. So that is why expansion limit of the stent, I think all of us should have that chart in the cath lab. What is where it can go?
But
latest
people go beyond what is recommended.
Yeah, that is each of us do a lot of things. A human body is great. That is different. But what is recommended, we should practice. And where you are doing crossover, probably there is some data with synergy crossover where the different strut attachment links in the synergy stent, that particular area where it is exposed to LCX ostium could be free from struts. But if you image and do a small type of cassole technique or whatever, minimal low pressure inflations, it is okay to just clear struts from LCX and do a crossover. But what is most important is to keep the expansion limit in mind and don't expand it too much beyond the expansion limit, because that could damage the stent. Sandeep?
Yeah, yes. Yeah, so I think the things that you need to look into is, of course, it is written on the thing, but it is the design of the stent. So if it is a closed design stent, like the Abbott vascular stents, and the number of connectors, where more number of connectors are there, 6 are there in Abbott vascular stents. So those are the stents where you cannot expand definitely more than one size. So that is the big thing. The other stents where number of connectors are less, like the Boston group or the Medtronic group, there, and also the second important thing, the design. So if the design is open cell design, like it is there is a spirally made stent, the Medtronic stent. These are the ones which you can expand even beyond can go to 1.5. So depending on what stent you are using, that also makes a difference on how much you can expand, and that size will be written, as he said, exactly on the thing.
So there is one point here. This entire kind of idea came from Onyx stent, which first started showing that my circumflex side branch, it can be expanded till 5 millimeter square. Then Nagomi came with showing 6 millimeter square we can expand. Then Synergy XD started showing we can also go to 6. And I tell you, most of the company now they're coming up with the same kind of idea and study or documentation that they can go to 5 to 6. So these are all company specific, not as such, but definitely we need to take into account their stent design, how much expansion it can take, and also the radial strength.
Other important point I wanted to mention for sake of juniors is, nowadays later generation stents are so trackable. Sometimes your NC balloons do not go, but stents go. So inadvertently, if you take and place the lesion stents there, stent fails to expand. Then you are stuck under expanded stent. That is more worrisome. So unless you are absolutely sure of preparing the bed, especially in the calcium-fied lesions, you don't have imaging, probably you can see in the two orthogonal views and see that balloon has expanded well. And then probably then only you take the stent in. Otherwise, the later generation stents, even if the suboptimal lesion preparation is there, it will go. But later on it doesn't expand, then you'll have a residual underexpanded stent. Then you'll be facing trouble. We want to take OPN balloon, expand it with high pressure and things like that. And then you sometimes are worried whether it will produce rupture, things like that. So be mindful of that lesion preparation, which is very important. And if you have imaging, you can always predict whether the lesion is preparation done or not. If you don't have it, at least see it in two orthogonal views and see whether the balloon is expanded well and see the optimal sized balloon again. If you have a 3 mm vessel, if you take 2 mm vessel, it could expand, but still it could be under expanded. So probably at least 80% of the vessel size, 100% of the vessel size and expansion, both orthogonal views. If unless you do that, don't take the stents, please, because these stents are trackable, expand well, but later on you will be left with an under expanded stent. I think in the complication session, we will discuss a little more about it. Any other doubts or any ask? Yeah, please.
So in case of underextended stent in ISR lesions due to calcium, what would be ideal strategy? Use of IVL or rotablation in case of ISR due to underexpansion or calcium? And what is the risk of stent fracture if we are using these IVL strategies?
No, this is for the sake of ISR, if you're using it, you use rotablation or anything only if the balloon cannot go. If the balloon can go, at least you make a place, and then probably that's where you have the role of OPN, or if a calcium is too deep and too long, that's where we prefer shockwave over a OPN balloon. OPN is cheaper, that's why we tend to get away with OPN if possible. But if calcium thickness is more than 5 mm and length is more little longer, more than 5, then that's where shockwave scores over OPN balloon. But if you are balloon not crossable, because shockwave balloon is okay, or NCL balloon is okay, but balloons can't go. That's where people try the laser or also atherectomy in ISR, but it's an off-label indication. That's not a standard indication, but we did some cases. And depending upon the calcium, the first stent fracturing, we are not too much bothered there, because anyway you would put another stent there. So only problem comes in the first time when you're putting, when you're expanding, whether the stent fractures there. That is what is a worry, especially with thin generation stents. But in ISR, so first generation, anyway, stent studs would crack. That's not a problem.
There are only 4 compelling indications. Like if you see a lesion, and this strategy will be the best, fitting. That is one is pinhole, access. Their rotablation has to be used. If you are seeing bifurcation with highly calcified lesions, then here you have to have a IVL, which is going to suit best. And then there is osteal disease. If there is osteal disease, try to use a BBL, IVL rather than using a rotablation or a orbital atherectomy where it can cause some out-osteal dissection. So these 3 are compelling indications. Pinhole, access, number 1, where nothing works like rota. Second is your osteal. Third is bifurcation. And fourth is maybe is if your access is more than 2.5 millimeter. So obviously, if you have a 4 millimeter vessel, there is a disease, and the access is still opening as 2 millimeter, 1.5, 2 millimeter. So there is no point going for a rota. You can straightway go with a IVL balloon. So these are 5, compelling indications. Rest in all scenarios you can change. You can go choose either IVL or rota depending on your access or what is available with you and what you feel most which comfortable with.
I think many of you also had a doubt regarding how to use orbital atherectomy versus rotational atherectomy. I think Ramesh mentioned that. I don't know how many of you could grasp it. If the vessel is proximal, the bigger size vessel, and that's where I think orbital atherectomy is scoring. Whereas the distal, little tortuous and thinner vessels, that's where I think rotational atherectomy is taken. And then probably more tighter disease, and where even the orbital atherectomy catheter cannot go, that's where people are still using rotablation. But RotaPro is almost like a orbital version, modified one with single hand one. How many of you are exposed to RotaPro? I don't know, but the same companies will change to RotaPro if you ask them to exchange the rotablation or the earlier versions. I think with this we'll close, we'll have some coffee break, and we'll come back after 15 minutes and exactly at 5:30 to have interesting discussions on complications. Many of you would want to learn from it, and we have experts like Sandeep others to discuss more about it and share our experiences on complications management. Thank you again. We'll reassemble
Before
back
we
at
go on a break,
Yeah.
I would like to request Deepa Nambia to felicitate Dr. Dilip Kumar. And requesting a round of applause. So, coffee break is for 15 minutes. Please try to come back as early as possible in the interest of the time.
Sure.
अभी क्या है? अभी कौन किधर से क्या? अरे उसको बोलना ये रखने के लिए स्लाइड उसको बोल स्लाइड यहाँ पर रखने के लिए जगह है next. Sorry, trust me, what has to be done? मेरे को नहीं मालूम है। अरे उसको पूछ हाँ इसमें कौन सा करना है ये फोल्डर है तो यही इसी में से तो मैच का कभी आएगा काम So we'll do it from here only. So I won't change the laptop. So next is I guess. We don't have the PPT for it. है लेके आओ लेके आओ लेके आओ I don't have the pen drive. नहीं one second that sir will decide now. So next we'll do this only. Then we'll go to session 3 direct. So we'll do this first. Yeah, from here only.
इसलिए हो रहा क्या देखता हूँ ये है ना
Video है
वीडियोस थोड़े हैं देख
ऑडियो लैपटॉप ऑडियो
नहीं उसकी ज़रूरत नहीं
हाँ ठीक है जिप सर
चल रही
You want to do it from podium mic or you want lethal?
नहीं
We do this right now. Imaging and psychology. Then we directly switch to Manish Kumar. Manish Kapoor. Session 3. Sandeep Mishra. Manish Kapoor will be my chairperson. Sandeep Mishra. इसका PPT दो मुझको फटाफट. Please और क्या क्या PPT है? ऋषि शेट्टी का PPT है.
शेट्टी आए हैं दीदी कम ठीक है ये एक मैं कर दूंगा उसके बाद
Done, sir.
बाकी के-
So I'll set this up now only. Make it a time basically. So now check. 1, 2, 3, check. Thank you. Take a minute.
Yeah, good evening, everybody. As people are joining back, I think there was some request to have this talk on how to choose imaging in clinical practice. I thought I would just finish it before we go on to the exciting complication sessions. Uh, yeah, I think it's up to you. Yeah, thank you, sir. Yeah, Dr. Upen Desai sir is here, and Dr. Manish Kapoor, is he here? He can. I think he'll come back and join. As people join, I'll take this time to give my talk on how to choose imaging modality in day-to-day clinical practice. Request all of them who are standing outside to come back and assemble for the further proceedings. Dr. Manish Kapoor, sir, please you can join. I think Sandeep, excuse me, some people wanted this imaging talk to be finished. I'm just finishing in 10 minutes, then we'll go to the complication session. Just next is that. So we have written this chapter on the intracoronary imaging, which one to choose when. Most of the thing I borrowed from them. Then there is no more discussion about my eyes are good enough and imaging is not required. After this masterly, I think, meta-analysis by Dr. Greg Stone of intravascular imaging, showing that in 12,000 plus patients, compared to angiographic guidance, the target vessel failures decreased by 1/3. The most dreaded complication of stent thrombosis is also significantly decreased by 52%. That is the strength of imaging, especially when you're dealing with more and more complex cases. The more is the utility of this. Then how do you what is the use of imaging in our day-to-day clinical practice? Is basically sometimes in diagnostic modality to assess the lesion severity, especially in the left main scenarios and eccentric diseases, and then sometimes to distinguish between morphology of thrombus or calcium, branch vessel disease in bifurcation. Therapeutically, that's a more and more usage, and for the precision PCI, the concept has come after this imaging technique has evolved. Stent optimization, expansion, then probably when to use the second stent, and the complication assessment like edge dissections, things like that, are actually more and more knowledgeable we became after the advent of imaging. And other area where imaging is mandatory and must, I would feel, is where the stents get into restenosis or thrombosis. And that's where I think imaging has a role. Newer imaging modalities, something need spectroscopy, angioscopy are all there, but most of it is research, but mere discussion is between IVUS and OCT. Actually, they both are complementary to each other. If we can have both, there is nothing like it, but for practical purposes, we cannot afford to have both. So most of the centers have one of it. And the operator compatibility is what is most important, I would feel. And then probably, as you know, the resolution is most with OCT. That's why the more thinner, more closer, more finer structures are visible better with OCT, but penetration is more with IVUS. So the deeper structures, the eccentricity, then all those deeper informations regarding the stent sizing are better with IVUS. But 80% of the times you can get away with either of these imaging modality, and what you are comfortable is most important. The sensitivity specificities are mentioned here. Then basically the calcium depth is more picked up by OCT, and because IVUS it shadows out. Then if you see this, I would request all of you to go through this paper of Sky statement on this how to do this. I think Sandeep will also cover this. So basically, as I mentioned, the thin cap fibroathroma, the thrombus, Plaque-Rapp calcification, dissection, which are more superficial, are all seen better with OCT. Whereas the deeper structures, like how much is the plaque burden overall, and the aorto-osteal disease, that's where I think IVUS scores maximum. The renally impaired patients, again, there's no doubt that we use only IVUS. So this instant restenosis, though we have either modalities to assess this, but probably there is more clarity and more less learning curve with OCT. So thin cap fibroathroma, the concepts came with OCT imaging. Then people wanted to do a trial comparing with both IVUS and OCT. This is OCT IVUS trial, and 1,000 plus patients in each arm. obviously it doesn't to show much difference because it is already the complications less is very difficult. So that's how I say that whichever one you are comfortable with, you can use it. IVUS advantage is easy acquisition. However sick the patient is, you can take the catheter in and out, and especially in patient also has renally compromised. The osteal lesions, again, there is no doubt that IVUS scores over. There are methods described with OCT also doing that extension catheters and things like that, but there's nothing to beat IVUS in osteal lesions. Higher penetrations gives the correct dimensions. That's how the OCT slightly underestimates the stent sizes, whereas IVUS quarter size more you can get. And that's how we become wiser now to add quarter size to OCT and take the same size as IVUS. This data of left main, what is appropriate size, came through this imaging criteria. Initially, it was said less as 5, 6, 7, 8, but again, for Indian scenarios and probably larger personalities, it is expanded now to 6, 7, 10. And the latest versions, again, with the latest same group of in Korea, they came out with recommendations for 8, 10, 12. Now, what you need to remember is 8 here, 10 here, and 12 there will give the best outcomes after the intervention. So disadvantages for IVUS, again, it is low resolution. It cannot image behind the calcium, cannot cross the calcific structures, and then image interpretation. Though doing it is easy, but you becoming comfortable with the interpretation of images, it takes a little longer curve. That's how I think people do imaging with IVUS, but they don't act upon what it comes out. But IVUS is definitely preferable in sick patients with severe early dysfunction, CKD patients with increased serum creatinine, no choice, left main osteal disease, and nowadays CKD patients, high, whatever amounts of creatinine, we are not bothered, zero contrast, low contrast PCI, we do with the usage of IVUS. And total occlusions, obviously, you cannot get images with OCT, so you use end-hole catheters with IVUS, and the ectatic aneurysmal segments, again, IVUS is preferable. I'll show 1 or 2 examples. See this osteal left main. This is what we were telling in LAO. Cranial views are the best to see the ostium of the left main here. So it is totally missed in the caudal views. Sometimes you see it totally there, critical disease. That's osteal left main disease. Then you image with IVUS, this is all the plaque burden. You measure the areas, you get significant narrowing in the ostium, and then probably there are multiple steps in it. For the sake of this, is a patient had severe early dysfunction, chip type of procedure with impella. We did this procedure. For the sake of time, I edited it, and we did stenting with an IVUS, again showing that entire vessels are reconstructed. Then left main also is reconstructed. The areas we got were very good, 13.9 in left main, circular expansion of stent, all that is seen clearly with IVUS. Then this is that of another patient who had a very critical left main, pre and post, and also had disease here. We did IVUS before, 3.5 area and 16.8 post-procedure. This is another area of osteal RCA. You think it a spasm, you have a doubt, you put a IVUS catheter, the area came very less, and then probably after dilatation, you do a good job, then it expands very well. Then this is we did in one of the live case just to demonstrate how OCT can show it. This is a catheter telescope which has a radiolucent tip. We could image even the osteal left main, but it's not the preferred modality. The disadvantages of OCT, again, the usage of large amounts of calcium. Contrast, now people are doing with saline too, but its rapid change portion is a little difficult to track, though the latest version of OptiStar catheter, it is better trackable. But OCT is preferable because it gives very clear images, and learning curve is very less. You can see up to the media thickness and visualize the EL very clearly in this. Instant restenosis, I would feel that is the modality of choice. Endothelialization of stents, whether stents got endothelialized or not, from VVS era to right disc, is very clearly seen with OCT. Stent underexpansion, malopposition is again seen very clearly. In bifurcation lesions is again OCT is preferable over the IVUS. The stable patients, normal renal function, good or mild LV dysfunction patients, smaller vessels, distal lesions, then bifurcation lesions, and post-PCI assessment, how the stent is optimized, and then probably precise stent placing, then whether any edge dissections are there. These are the preferred scenarios where OCT is preferable. Beginners, again, it is easy to learn and assess the learning curve is very less with OCT. The morphology assessment, the MLD Max concept which came with OCT is again way ahead compared to IVUS in assessing the morphology of the lesions. You see like almost like a histology, the intima, media, external elastic lamina very clearly. The morphology, calcium preparations and how the lesion is fibrotic, lipidic, moderate calcium, severe calcium is again assessed very clearly by OCT. And depending upon the depth and thickness and length, you decide what type, that's the rule of 5, decide whether to use OPN or ablation method, shockwave and things like that. This is another area where usage of OCT is picking up in our country, especially in 31-year-old male fellow smoker, and then comes with anterior wall MIC, that thrombotic lesions there, and then large burden of thrombus. We were at loss to see whether to stent it or not. We gave heparin and then brought him back. But still, if there is a plaque rupture, you are supposed to stent. If it is only erosion without the plaque down, then probably you can leave with medical management. This patient had a plaque rupture, and that's how this patient had stenting done, and then he had a OCT done post-procedure, and result is quite good. Other area where the stent under expansion is what is most important to cause for TLRs happening. So this is very, very clearly seen with OCT, and we are supposed to get at least about 80% expansion compared to proximal and distal vessels, and this has a lot of advantage. Malapposition, which was thought to be very important, because unless it is grossly malopposed like this, less than 3 mm malapposition is still okay, but under expansion is what is more dangerous. Dissections, like mild ones are okay, but this sort of intramural hematomas, medial dissections extending to more than 1/4, that's where I think we need to act upon by putting another stent. This is one interesting case, a 15-year-old patient of ASD with a large Eisenmenger. When this angio was done, this sort of tight lift main. Actually, when we analyze and see this, the pulmonary artery was compressing. You have methods to remove that and then see that. Then patient was getting angina recurrent symptoms, though we explained it's not a curative treatment, but just to prevent her from going to LVF and ischemic angina. Then this is the third just I shared. Initially we did IVUS, then for sake of time I'm doing, then for sake of, that's a slit-like ostium of left main. Then we had wired both. And then left main ostial stenting. After that, positioning correctly again in a leocranial view, then you flare the stent. That's the appearance we got. Then we did OCT again, and we got good result, and IVUS also showed a good expansion. ISR cases, again, there is no definitely OCT scores over it. The various which types of ISR is happening, depending upon it, you take a decision. This sort of patients who come with crescendo angina with old inferior wall MI, he had again right coronary artery stenting done, again it got occluded. The concepts again, after wiring it with difficulty, then probably predilatations, you take pictures with OCT, and this basically shows wherever there's a DES already before, you tend to do DEB. Where there's a new restenosis happened, probably you can put another layer of stent. That's how the entire arteries are being reconstructed with planning of OCT. The entire artery is again becomes normal after the procedure. This is another patient, that's a right coronary artery imaging came. This is another patient who came back after 10 years of the procedure, but he had a little more distal LCX lesions, which was missed totally by angio, but probably it came in OCT, then it was tackled. This is a 17-year-old male patient with raised creatinine again. So we did IVUS here, and again neointimal hyperplasia, all that was treated well, and post-procedure we have got good results. So that's how I think we need to take decisions depending upon what lesions we are dealing with, and then act upon it. OCT again scores in bifurcations. We all know how you can assess the bifurcation lesions, and then probably kissing, and sometimes the struts lead to restenosis. That's how we now do a gentle dilatations, and then fly-through views inside, you get very good pictures in bifurcation. Just to conclude, I think I wanted to be brief now because we are running behind the schedule. So now, sick patients, LV dysfunctions, CKDs, osteal lesion, you prefer IVUS. Whereas patient is stable and no problem, normal renals, you want to assess the morphology of lesion, and then probably you want to assess instant restenosis, what is the cause, and then probably in sometimes in ACS, and then these are the patients who benefit by OCT. And again, by and large, I would like to say 80% of the times you can get away by both, but only message is you need to act upon by what comes out in the imaging and then accordingly take decisions so that patients do well and follow up. Thank you for the patient hearing. I think with this I'll stop and we'll go to interesting session of complications. Thank you.
Thank you, Dr. Kumar, for a very nice presentation. Are there any questions? I think IVUS and OCTs are going to be the future, you know. More and more we do complex angioplasties, we will be requiring imaging. So I think all of you need to be little familiar with the imaging modalities. Any questions for Dr. Kumar? No, you spoke so well, everything is clear.
No, so maybe one condition where both are present, but you will prefer one over other. Or maybe the one device is giving you wrong information, then you would like to use the other also.
I always say the osteal lesions, again, there is no replacement to IVUS because once you go in, you can easily assess the aorta, and after stent placement also, you can see one or two struts coming up, again coming into the aorta. All that is seen very clearly. There's no point trying to put a telescope catheter which has a radiolucent and again take pictures with only OCT. Not the question, if you don't have IVUS, that is a different story. But the osteal locations, I think, where the IVUS scores, and then another area is CKD. People are again trying with saline, other things. If you don't have IVUS, again, there's no choice. You can try with saline, other things. But when IVUS is there in patients of CKD, and now we do zero contrast PCIs. Patients do come with creatinines of 6, 5.6 now, where we run procedures with zero contrast only. In the end, we take 3cc, 5cc to document that every result. But by and large, again, in CKD patients where IVUS scores. On the other hand, if you have to tell one de-indication for OCT, I feel instant restenosis problems, ISRs. I think that's where I feel OCT can give better information. And the newer softwares which are coming up with the bifurcation modalities assessment, whether you have to use 2 stents, 1 stent, distal strut crossing, proximal strut crossing, those are better with OCT. Those are particular scenarios as Sir asked, I mentioned, but by and large, 80% of the times you can do both. But one thing I want to mention is people do imaging, just run the catheter, come out, don't act upon it. So that is not actually recommended. So at least take some time and see what is there happening, and then try to analyze and do accordingly. Otherwise, just putting an imaging catheter and people come out, good and bad is there everywhere. I'm not talking about these things. By and large, that sort of practice is to be avoided, and try to analyze what came out in the imaging and try to act upon it. Most important other thing is after the stenting procedure, I have another talk, actually I didn't make it, ambiguous angio appearances. After the procedure, you feel whether the edge dissection is there, where some haziness is there. That's where OCT scores beyond, actually. It gives very clearly, tells you area is good, or dissection, intramural hematoma, some things what I've shown are very clearly made out. And once you come out with a good imaging post-procedure, you have no doubt how the patients will behave. Patients will behave all right. The initial results, even with imaging, are good. So that's why it gives a lot of confidence to do complex cases. So somebody asks me where you have to absolutely use imaging, definitely is one area is instant restenosis, second is left main. Obviously, you can, if you don't have imaging, please refer the patient somewhere else, because angiography-wise, it looks like 3, but if you see imaging, then probably you get bigger diameters. And same type of angiographic appearance in the 2-dimensional view, when you post-dilate again, the areas keep on increasing. So that's another area where you should definitely do imaging in left main lesions. I am happy that in our country also imaging is going up. And these two are absolute areas where you should not attempt doing PCS if you don't have imaging modality. Other things like bifurcation and especially left main crossovers, again, I feel imaging is mandatory. But other places, if you still want to do it, it's up to you. But these are areas where I think you should not compromise the patient quality of results get affected without imaging. Can you pass? Give one. Take.
Imaging in my cath lab, my unit is around 80 to 90%. Like almost every patient gets an imaging. And what I interpret as a OCT and IVUS, IVAS you can take many times, 4 times, 5 times, 6 times. You have a complete control over the catheter. You can stop the catheter, you can see what is happening. You can just manual, pullback you can do. You can stop the catheter at ostium. You can stop the catheter at a place where you're ambiguous and we're not very clear, you can see. So, so IVAS, if one imaging modality has to be there, it has to be only and only IVAS. There is no proven data with OCT, which has conclusively proven that OCT is superior, or even it's superior than angiographic basic, best, treatment. And finally, I treat operators in two, categories. One who is patient friendly. Patient friendly means one who is going to give less contrast to this patient, one who is going to give better result to this patient. He will always choose an IVAS. Someone who has all other kind of thought process, flamboyance, and maybe OCT can be there, but IVAS is the must if you are choosing for the one.
I think latest HD IVAS is good, Dilip, but earlier version of IVAS imaging was not that clear as OCT. Latest HD IVAS catheters, agreed, they are much better in imaging quality, and learning curve is also decreasing. Whereas OCT, once you get a good picture, even the fellows can make out the dissections and things like that, the clarity which it gives.
In a larger vessel, OCT, in fact, it doesn't penetrate there.
No, true.
And then you have to give, if you have to do 2-3 runs, 60-70 ml of contrast is
gone. I agreed.
30-60 ml of extra volume is going all of a sudden. And patient in MI, myocardial infarction, interval MI, you are pushing a lot of contrast. This can be detrimental.
Yeah, that's why I said in ACS and MI, hemodynamic unstable patients never do. IVAS is preferable.
Philips IVAS, the images are not good. HD IVAS, I think it can match OCT in terms of.
No, he has clearly shown the benefits and advantage and disadvantage of both the procedures. They are not competitive to each other. They are complementary.
Yeah, I think static, recent IPCI meeting I showed the left main ostium. We have now started doing what is called as static IVAS imaging. Just put the catheter there and image, and you get a lot of information that way also. And the more data is coming up with static IVAS imaging. I think this imaging can have some discussion further with complication session. Don't want to again further delay. Many of them are eager to hear to Dr. Sandeep, and he being Vice Chancellor, and in spite of all his busy schedule, he speaks very well on this topic. That's why I caught hold of him and again asked him to talk on this complication session on instant thrombosis and restenosis prevention and management. Gradually, some of them could be overlapped. That's why we clubbed this. Let us hear from Sandeep. This complication session, I think at least you can have some questions, interactions, because all of you face, and any doubts you have, not only the complications you have mentioned here, any other doubts also you can ask.
So, good evening, everybody. First of all, I have to thank Dr. Srinivas Kumar for calling me again for this. I came in last year as well. So what he has tasked me to do is to talk about two complications, stent thrombosis and in-stent restenosis. So, a lot of us thought that stent was the final solution. But after some time we started having these complication sessions because we realized that stent had some issues. Some of them were technical while doing the procedure, and acute stent, even stent fracture, dog boning effect, recoil effect, and some of them were like after the procedure. So the two procedures, the two things which commonly happened after are of course restenosis and stent thrombosis. There is an acute stent thrombosis which can happen at the time of procedure, but maybe we will, others will also cover it. But I'm talking of later complications basically. Now coming to stent thrombosis, what has happened? I think, okay. You can see, coming to stent thrombosis, it is a rare but devastating complication. It is as rare as less than 2%, and different series will show you different numbers. Definitely should be less than 2%. But the mortality rate could reach as much as 50%. So this is the big problem, that while it is rare, but if it happens, then it could be a serious problem. And the stent thrombosis is been defined as a time at which it happens. So it could be acute stent thrombosis happening within 24 hours, and this includes intraprocedural stent thrombosis as well. But there is subacute, which happens more than 24 hours to 30 days early, which is less than 30 days, but less than a month, then late between 1 month to 1 year, and finally very late, which is more than 1 year. Of course, as you may see, that intraprocedural stent thrombosis is a type of acute stent thrombosis because it happens within 24 hours. Late thrombosis generally came in when we came with a new kind of scaffold, that was biovascular scaffold, and then we saw many cases of late stent thrombosis. So we'll touch upon them one by one. Basically, ARC, which is the consortium, divides it into 3 groups: definite, where you are definite that it is stent thrombosis, probable, and possible. So these are the 3 classifications, because I will not go into a lot of details because we don't have that much time. But as you might have see from this slide, various trials I have quoted, and you can see that acute stent thrombosis, the prevalence could be about 0.9%, subacute 1.5%, late 1%. Overall, these are little older studies. Overall, it was like 3%, but any good person will have stent thrombosis rate less than 2% in 1 year. So coming to history of the thrombosis, at the bare metal stent era, the stent thrombus was very common, up to 20%. With incoming of stents, improvement in the quality of stents, the bare metal stent thrombosis rate came down to about 2% or less. And then, of course, came in the drug-eluting stents. And with drug-eluting stents, initially there was a higher stent thrombosis because of various reasons, polymer, etc. That was there in the drug, that was there in the DES, and also the drug itself possibly causing some stent thrombosis. But over a period of time, with improvement in design of the stent, in the quality of stented material and the polymer, basically, the amount of polymer coming down to less than 5 micron in thickness on the stent surface, or even less, and better and better polymer being available, this rate of stent thrombosis has fallen down. And now at the most, you may say, good places, it would be up to 1% only. So now, as I already discussed, the rates can vary. 2% is acceptable. The consequences are not acceptable. 50 to 80% risk of acute myocardial infarction, and nearly 50% risk of half people will die of stent thrombosis once it happens. Interestingly, most people will die actually if they don't get treatment for stent thrombosis. So if they don't get another procedure very quickly done, then they will die. If they get it done, then most people will be saved. Acute stent thrombosis, one important thing to remember, that if you look, why timing is important, because the cause of stent thrombosis varies. If you talk of acute stent thrombosis, the most important cause of acute stent thrombosis is procedural, intraprocedural. It is operator dependent. So something operator has not done well, and that is why that thrombosis has happened. But if you look at subacute stent thrombosis, it is mostly related to people having not good antiplatelet therapy. So either the dual antiplatelet therapy, maybe the patient has stopped taking, or the proper choice of antiplatelet drug has not been made, or something like that is most common cause for subacute stent thrombosis. For late stent thrombosis, it is the stent design mostly, particularly with BVS, that was the cause. Now, having said that, we have to look at the risk factors when stent thrombosis can happen. They are patient-related factor, procedure-related factor, and post-procedural factors. The diagnosis is, of course, commonly made with coronary angiogram. That has been the gold standard for diagnosis. But now IVUS and OCT have also come in, and they can help in various situations, especially, if there are some other problems which is causing the stent thrombosis. So finding the reason for a stent thrombosis, particularly the technical reason, whether it's because of dissection, under expansion, maloppositions, that information will be provided by the invasive investigational technique. Talking a little bit about bioresorbable scaffolds. So when they came in, it was thought to be a very good idea. They were something, you need a stent only to give support for about 6 months. After that, that support is not needed. So after 6 months, that metallic thing is practically useless, but it continues lifelong. So the idea was that if you put something which gets resolved within 6 months, it will be a very good idea. Then the stent functioning, then the vessel functioning will also be good. Physiology of vessel will be very good, because vessel is supposed to expand and relax. With a stented vessel, that thing does not happen. It is caged. So with a bioresorbable scaffold, it was thought that once the scaffold goes away, the vessel will become pristine physiological structure. But what happened was that over a course of time, they realized that there were a lot of thrombosis and even restenosis. And the reason for thrombosis was because it had a low radial strength, so that it could not get properly embedded in the vessel wall, and therefore this problem started. So with better design, with better technique of implanting, the problem might have been relieved. I talked about intraprocedural stent thrombosis. I will not go into detail because I've already told you mortality is high even here. Here are some of the predictors for stent thrombosis, which can predict. And actually, Dangas has given a score even before doing 1 to 4 going low risk, 7 to 9 intermediate, and greater than 10 high risk. So if you have high risk features, then you need to be very careful with these procedural and post-procedural factors, incomplete stent coverage, under expansion, edge dissection, and non-use of GP2B3 antagonist in high risk cases will be a problem, and they should be controlled. Of course, there are lesion-related factors also. Anybody who has come with acute MI or acute coronary syndrome is likely to have a risk of stent thrombosis, and there are many other lesion characteristics as well, as you can see. Then among the patient-related factors, as I said, patient presenting with STEMI, but also diabetics, CKD, renal failure, and very low ejection fraction are also predisposed to developing this particular problem. Important thing to remember that in early stent thrombosis or acute stent thrombosis, dual antiplatelets are not important because it is because of procedural reasons. It is something wrong procedure done by the operator. But later on, these become very important. And when you have high risk, obviously, as I said, GP2B3 inhibitors must be considered because to prevent this risk. Then talking about a little bit about this KS-induced or Cossini syndrome, which is actually an allergic kind of stent thrombosis, which is recently found when everything normal is done, but still patient is getting stent thrombosis, and could be because of environmental exposure of things, drugs, and some other food conditions as well. So prognosis, as already discussed, is not very good. Prevention, as I already said, proper do risk stratification. And once you identify that, then you have to be very careful with the procedure using imaging techniques and making sure that your results are very good. And a proper usage of dual antiplatelet, maybe something like ticagrelor should be used here, definitely. And in case you are not sure of the drugs, then you can also do certain tests to look at antiplatelet efficacy. So stent selection, stenting technique, and proper use of antiplatelets is the most important thing. In some cases, you might even require IV cangrelor or as GP2B3, as I already discussed. Stent design is also a thing which you could do if you think the patient is high risk for stent thrombosis. We already discussed those designs, Onyx, and some new designs with Boston Scientific as well, but these should be considered. Now coming to in-stent restenosis. In-stent restenosis is basically narrowing because of two reasons. Either it could be new intimal proliferation, or it could be neoatherosclerosis. So these two things you have to realize. This is the history of how in-stent restenosis therapy is developed, how its management improved over a period of time. Broadly, if you see, if you do plain POBA, then risk of re-narrowing is 50%. If you implant bare metal stent, then the risk will become 20 to 30%. So from 50, it will become half. But if you use drug-eluting stent, it will fall another at least more than 50% and become 5 to 10%. But still the risk may be higher in diabetics, long lesions, and there are certain subsets. But these are the typical risks of in-stent restenosis. As I said, other factors also influence. Other than the stent type, diabetes, CKD, smokers, risk is higher, and some of the lesions, the risk may be higher, as already discussed. The mechanism is that the injury that has been caused, what happens is it stimulates a lot of pro-inflammatory cells, and these pro-inflammatory cells secrete a lot of things, and as a result of this, smooth muscle, actually, this is the, as I said, I was discussing, the smooth muscle gets activated and it starts producing multiple layers, and this neointima, and the intima actually, instead of one layer, becomes double, triple, 4 times, and this neointimal proliferation is one cause, the other cause being neoatherosclerosis, as already discussed. Now, of course, there has been a huge impact of in-stent restenosis as well. There is a clinical impact, but also economic, and in design also, new innovations in stent have happened because of in-stent restenosis. Clinical decision making has improved because people realize what we do now will have impact later, so better take better clinical decisions so that later is good and quality of life of patient is affected. How it is affected? There could be recurrence of symptoms. There is less, I mean, between the stent thrombosis and in-stent restenosis is more common, but more benign. So lesser risk of MI and practically very less risk of mortality. Some cases it can happen indirectly, but very less risk. In stent thrombosis, the risk prevalence or incidence is less than 2%, but risk of MI is 50% and 80%, and risk of dying is 50%. So this is the difference between the two. Of course, you know, if you put in more stents, more patient comes to a hospital, the economic impact is higher, and it also stimulates innovation in stent technology, improves clinical decision making, and improves quality of life of patient. It does not happen. How to investigate? I think I'll skip most of it because we have already discussed. CT angio is the first, you can use it to detect. Then coronary angiography has been the gold standard to basically find out re-narrowing. Ultrasound is good because it is more important. OCT also shows the same thing. A fractional flow result gives idea about the functionality. Histological examination is the final thing if you can get it done. Prevention is, of course, better than cure using newer generation DES. Optimizing stent deployment and aggressive medical therapy is the way to go about it. Considering the treatment, the gold standard have been, you know, repeat PCI with another stent if required, or sometimes only POBA, but drug-coated balloon is another idea, especially when it is a small vessel. I'll just take a couple of seconds more now. If it is basically a small vessel, or if 2 or more layers have been added, then drug-coated balloons are a good idea. In some cases, somewhere brachytherapy is always also available, especially where DEB is also not successful, stenting is not successful, still restenosis is happening, then this is brachytherapy that can be delivered. When I was working in Washington, this center was the biggest center for brachytherapy in the world at that time. Finally, of course, bypass surgery. So this is one classification, and I think I would like to I wanted to spend some time on it, but this gives you exactly what to do when. And this is from Washington Hospital Center only, my boss, Ron Waxman, his slide, and this I think is very important. If some of you might want to click a picture, it would be a good idea. This is the usual running scheme of how you would tackle in-stent restenosis. So thank you so much for your kind attention.
Thank you, Sandeep. Please join here. I think we'll have discussion after of all the complications talks. I think we have Another very dreadful complication which all of us are worried is about perforations and ruptures which happen. Peripheral coronary dissections we manage, but we requested head of the department, Sri Venkateshwara Institute of Medical Sciences, Dr. Rajshekhar sir, to come and deliver his talk and share his experiences of how to avoid and what to do when we encounter this deadly complication of perforation.
Good evening, everybody. I am thankful to Dr. Srinivas Kumar for giving me an opportunity to speak in this gathering. I am asked to speak about coronary dissection, perforation, and rupture. As we all know, dissection, perforation, and rupture are known complications of coronary angioplasty. And up to 30% of coronary angioplasties have some evidence of angiographically visible dissection, because basically PCI is produces plaque rupture, intimal splitting, and localized media dissection. And when it extends into the adventitia, it is referred to as perforation. National Heart, Lung, and Blood Institute has classified the dissections into 6 categories, starting from A to F. All of us are aware of this. In A and B, the contrast doesn't stay in the coronary artery after the injection is over, and the contrast clears, whereas in the category C to F, the contrast tend to stay there, and in category F, actually there is no distal flow, the flow stops. So dissection types A and B are actually a good prognosis, whereas dissection category C to F, when left alone, can lead to serious complications. Generally, as I said, generally A and B dissections are benign. Type C to F, potent morbidity and mortality if left untreated. Acute vessel closure to dissection occurred in up to 10% of the PCI in the pre-stent era, but however, with the advent of the coronary stents in the last 3 decades, this problem has almost been fixed, and we rarely have flow limiting dissections, and such incidence is less than 1%. But however, there are 2 significant groups of dissections which are very important in the current day scenario. One is the edge dissection, and the other one is the ostial dissection of the coronary arteries. Coming to edge dissections, these have been increasingly picked up in the current era because of intracoronary imaging, both IVS and OCT. After deployment of the stent, there could be dissections at the edge, both proximal and distal, and it is possible to quantify these edge dissections with the help of the intravascular imaging, which can be OCT or IVS. And basically, you measure the depth of the dissection, the length of the dissection, the extent of the circumference of the arc which this dissection covers. And once we measure this, we can decide whether we need to put an additional stent to cover these edge dissections, or whether this can be left alone if the dissections are minor. Other important dissection which is very relevant in today's practice is the iatrogenic catheter-induced ostial coronary artery dissection. This type of dissection could occur with both diagnostic catheter and guiding catheter. The right coronary artery, the left coronary artery, or the lima or the SVG graft ostia may be involved in dissection. The incidence of these dissections are fortunately rare, and they are categorized as 1 in 1000 or 0.1%. Most of the time these dissections occur because of deep intubation and traumatic intubation. The presence of ostial disease actually predisposes to the development of ostial coronary artery dissections. And the sad thing about these ostial coronary artery dissections is that most of them fall under the category C to F described by the NHLBI. Type A dissections of the ostium may actually go unrecognized, and the type of dissections, if we don't treat, the in-hospital mortality is as high as 6%. Most of the time the ostial dissection occurs when we are in quest for extra support. Use of EBU catheter and Amplat's left catheter for right coronary artery PCI most often causes ostial dissection of the right coronary artery. And more than 10% of the LMCA dissections occur even at the first attempt of LMCA engagement. In one study, it was shown that when the 24% chance of LMCA dissection in the presence of a plaque within 6 millimeter from the tip of the catheter that is engaged in the left coronary arteries. On the other hand, if the distance between the tip of the coronary artery and the left main lesion is more than 6 millimeter, then the incidence of left main dissections during the engagement and procedure is quite less. In the presence of left main ostial disease, it is always necessary to have the coaxial engagement of the catheter into the coronary, else during manipulation of the wire or during contrast injection, the LM could dissect. Most often we do the radial approach, especially the right radial approach, with the use of the guiding catheters which are made for the femoral use. So such catheters need some manipulation before they can be engaged into the into the coronary arteries. So during such engagement, a dissection of the ostium of the right or left coronary arteries can occur. That's why when we use these catheters from the right radial approach, the incidence of ostial dissection is more. On the contrary, when we approach to the left radial artery, then the incidence of dissections are less. Ostial dissections occur more common in female patients, and most of these dissections, especially if they are of type A or type B, can be observed, but type C to type F need some intervention, and the intervention is usually stenting, but in rare cases, coronary bypass surgery will be required. As I said, most of the time these ostial dissections are because of guiding catheter occurs during guiding catheter placement, but it can also occur during contrast injection while attempting to pass a wire or advance a balloon or a stent or even a guide extension catheter. Most important thing that we should remember is ostial dissections could occur when you have finished the procedure, finished stenting, and you are trying to take out the balloon after the stent implantation. What happens is that at that time the guiding catheter tends to get sucked in and it could dissect the ostium. In fact, in most cases when ostial dissection occurs, a combination of several of these factors could occur leading to the ostial coronary artery dissection. In one study it was shown that most of the cases of ostial dissection is the left main coronary artery, the EBU catheter is a culprit, whereas most of the cases of right coronary ostial dissection occur due to usage of Amplat's left catheter for engaging the right coronary artery. So this is an example of ostial dissection of the right coronary artery produced with the usage of Amplat's left catheter. Management strategies for these ostial dissections, as I said, are threefold. One is conservative, second is angioplasty, and third is the surgery. Once the patient is stable and the category of dissection is A, then he can be managed conservatively. But in more advanced dissections, a stent should be placed. And it is quite easy to place the stent once the wire is across. But sometimes there is an hematoma which is extending into the aorta, during which time ordinary stent placement in the ostium of the coronary artery may not be sufficient, and some repair for the aorta may also be required. Sometimes this hematoma may extend back so much that may induce even aortic regurgitation. There is some need for surgery also in patients who have ostial dissections, because in some occasions you have not yet wired the vessel and the ostium has got dissected, and after repeated attempts you may fail to wire this artery and the patient may become hemodynamically unstable, during which time he may require a coronary artery bypass surgery with repair of the aorta and sometimes even an aortic valve replacement. The next thing that we will be talking about is the perforation of the coronary arteries. Perforation of coronary artery is defined as evidence of extravasation of blood or contrast from the coronary artery during or after the PCI. Basically, dissection or intimal tear extending into all three layers of the coronary artery, that is, even the adventitia is involved. Coronary perforation can occur in the proximal artery or it can occur in the mid or distal artery. Distal perforations may remain silent, whereas proximal perforations will often produce serious symptoms and hemodynamic compromise. And the perforations are currently estimated to occur in about 0.2 to 0.5% of the percutaneous interventions. The predisposing factors for perforation can be categorized as patient factors, lesion factors, and the procedure factors. The patient factors, elderly female patient who is frail is most predisposed to develop coronary artery perforation. Perforation can occur in the setting of PCI in both ACS and chronic stable angina. The important lesion factors include small caliber vessels, total occlusions, calcified arteries, bifurcations, angulated arteries, tortuous arteries, eccentric lesions, and the tapered arteries. We can say that the PCA of ACC-AHA type C lesion is more prone for perforation as compared to type A lesion. And the procedural factors include inexperienced operator, then usage of hydrophilic wires, stiff wires, then usage of oversized balloons, high pressure dilatation with semi-compliant balloons, usage of cutting balloons and atherectomy devices. With all these, there could be higher incidence of perforation. Not that perforation will occur always, the incidence of perforation will be higher. Usage of 2B, 3A inhibitors also can predispose to perforation, and should perforation occur, there may be more dire consequences if the patient has received 2B, 3A inhibitors also, especially the abciximab. Should perforation occur in a patient who has received abciximab, simple stoppage of abciximab may not be sufficient, and it may be necessary to give platelet transfusion also, because the platelets are irreversibly inhibited for about 36 hours. Then we need to classify the perforations into types, and the one which was described by Ellis in 1994 is widely followed. In type 1 perforation, there is an extraluminal crater without extravasation. In type 2, there is some staining and pericardial or myocardial blush, but the size of the exit hole is less than 1 millimeter. In type 3 perforation, the exit hole is more than 1 millimeter in diameter, and there is extravasation into the pericardial cavity. Then we have the type 4 perforation, where extravasation occurs into the chamber. It could be the coronary sinus, it could be the atrium or the ventricle. And type 5 perforations or guide wire perforations, which are distal. When we are very careless, we concentrate only on the procedure and don't bother about the tip of the wire. It could perforate distally and produce pericardial effusion. And type 6 perforations refers to perforations which occur at special situations like venous grafts and Lima grafts. There are other classifications also, but most classifications take into account only whether there is extravasation of contrast and blood or not. When there is no extravasation, then the outcomes are good. If there is extravasation, then the outcomes are not that good. The consequences of perforation is that some of the perforations may actually remain silent. Sometimes procedure is completed and the pericardial effusion is detected after 6 hours. And in patients who develop SVG graft perforation, there could be actually extravasation of blood into the pleural cavity and produce symptoms due to blood loss. Then other common symptoms are myocardial ischemia, infarction, arrhythmias, both tachy and bradyarrhythmias, cardiogenic shock due to cardiac tamponade, and perforations can lead to death on table also. So once perforation is diagnosed, we should institute the supportive measures immediately, which include IV fluids, oxygen administration, then analgesics if patient has pain, and inotropes, atropine if there is bradycardia, then pericardiocentesis if there is evidence of cardiac tamponade. And when we do pericardiocentesis, we should do autotransfusion. Sometimes even IABP support may be required if there is severe hypotension and cardiogenic shock. Then we have to reverse the heparin with protamine. And once the perforation is diagnosed, we need to do the ACT also. and also have the echocardiography immediately. So management of perforations can vary whether it is type 1 or up to type 5. In type 1 perforations, usually simple balloon dilatation for prolonged periods may be sufficient. Sometimes covered stent may be required. In type 2 perforations, more often covered stent will be required. In type 3 perforations, these are the perforations who are usually not stable. They will have hypotension and they will have cardiac tamponade, and therefore we have to activate the surgical team, the anesthetist, as well as get the echo in motion immediately. And we should also do the ACT and reverse the heparin. Then we should place a balloon. Then if balloon dilatation doesn't stop the flow, this leakage of contrast, then we should place the covered stent. In type 4 perforation, there is a leakage into the cavities. These again respond very well with covered stent placement because that will take care of the steel which will occur to the distal coronary artery because the blood is flowing into the cavity. In type 5 perforations, which are guide wire tip perforations distally, they are easier to manage. We can place a balloon in the proximal portion of the coronary artery and inflate it at low pressures. Then the guide wire induced distal perforation is likely to seal off. Coming to the technique of balloon dilatation, we have to use a balloon which has a ratio of 1:1 with the artery involved, and low pressures are enough. High pressures should not be done, and it should never exceed 8 atmospheres. And we should keep the balloon inflated for about 5 minutes and then deflate and then check and with an angio and see if the bleeding has stopped. If it is not stopped, we can repeat the cycle, and balloon dilatation can be done for up to 30 minutes in 5 to 6 cycles. If the patient is not tolerating the balloon dilatation, one may use a perfusion balloon. Once the balloon dilatation fails, we should go for a covered stent. Nowadays, covered stents are available, various preparations, we will come to them shortly. And if the patient is stable, we can remove the balloon and then thread the covered stent and deliver it. But most of the time patient is not stable. In such case, we should put a second guiding catheter, put another wire and then deliver the covered stent through the second guiding catheter. At that time, we can deflate and remove the other balloon and wire. So these are the various available covered stents. They may be stainless steel or cobalt chromium, and they may have a sandwich model like in the Joe stent of Abbott vascular, or they may be having a single layer of stent. Their profile also differs. Available length and diameters also differ. In fact, there are covered stent made of equine pericardium also. So we can, they may be PTFE or polyurethane. So their profiles are different and the recommended guiding catheters are also different, but most widely used covered stent is the what Joe stent or graft master of Abbott vascular. The problem with this stent is that its profile is very high and it may be difficult to deliver it through angulated lesions, and large size covered stents of Abbott vascular require a 7 French guiding catheter. Most of the time we are doing a procedure with 6 French guiding catheter and we may have to remove it and engage a 7 French guiding catheter. Alternatively, we can put in a second 7 French guiding catheter retaining the 6 French guiding there itself. So here you can see this is a sandwich model. There are 2 layers of stent and the graft material is in between in the Joe stent, whereas the other stents have lower profile because there is single layer of stent and covering on that stent. The covered stents also have a higher incidence of stent thrombosis, about 6%, and restenosis rates are also very high. This is a diagrammatic representation how to go ahead with the usage of second guiding catheter one, retaining the first one there itself. This chart compares the 2 commonly used covered stents, namely the Papyrus and the Joe stent of Abbott vascular. Pericardial covered stents, if available, should be used more frequently because they have a lower profile and very flexible, and therefore it may be easier to deliver. Once if covered stent fails, one can try coil embolization, and usually the platinum coils of Terumo are used, and these coils can be of two types, namely the pushable coils which are pushed with the help of a guide wire, or the deliverable coils which are delivered with the help of delivery system. The problem with the coils is that it requires a microcatheter and also an experienced operator to deliver the coils. If coil embolization also fails, thrombin can be tried. A solution of thrombin is prepared and then it is stacked with contrast, and over the wire balloon is placed. The guide wire is removed, and through the guide wire lumen, thrombin solution can be injected. The important thing is that when you are injecting the thrombin, you should have the balloon inflated so that the thrombin solution doesn't spill into other areas. And in fact, the balloon should be kept inflated for about 10 minutes after the completion of injection. Other things which can be used when nothing is available is the subcutaneous fat autologous obtained from the anterior abdominal wall, and it can be injected with the help, through a microcatheter. And other material like clotted blood or gel foam can also be used. And at the end, we may be left with a situation wherein we have been successful in sealing the perforation or unsuccessful. If we are successful, the patient should be monitored for 24 hours in the ICU, echo repeated, and catheter removed after 24 hours when the drainage is less than 50 ml per 2 hours. If we are unsuccessful, despite all the measures, then the patient may have to be referred for emergency surgery. And pericardiocentesis is something which should always be available in the cath lab, especially if we are a busy center doing a lot of procedures every day. Emergency surgery, the problem with that is that the mortality rate is as high as 50% in these type of cases. So it is better to prevent coronary perforation than treat it. And to prevent coronary perforation, we should use soft wires first and escalate wires slowly, and have a loop of the distal end of the guide wire so that it doesn't inadvertently injure some structures distally. We should not use oversized balloons, and we should not use high pressure dilatation with semi-compliant balloons. And we should minimize the usage of the 2B3A inhibitors, and we may avoid using bivalvulotin because there is no reversal available for bivalvulotin. Coronary rupture is actually the next step, and actually it is difficult to manage coronary rupture with percutaneously. And should coronary rupture occur during angioplasty, the patient will require in all probability a surgical management. Thank you.
Thank you, sir. Please join here. Shall we finish my talk also, then go to discussion? I think Rishi Sethi is just coming. He is told that his flight is delayed. He will be coming. I'll give the general talk about complication prevention and management, and then go to the individual again in the end of the discussion. Yeah. Yeah, good evening again. Nightmares or complications in cath lab is again deadly, and we should learn from others' mistakes rather than we doing it. So I borrowed this slide from Bilakis regarding the complications which can happen during PCI. Some are non-cardiac totally. That is regarding the vascular access problems which can happen, or thromboembolic complications, or contrast-induced nephropathy, radiation injury. Those are totally not related directly to the procedure. But vascular access complications are very important, especially in structural heart interventions, which will be covering tomorrow. Then non-coronary complications like hypotension, arrhythmias happening, again become important. And sometimes myocardial infarction, though, could be procedural related, or sometimes for other reasons too. But what we are more interested is the coronary vessel closure, dissections, and thrombosis is already covered. And then some of these perforations, which is Sir has shown. We'll also try to show one or two case examples. And the equipment loss or entrapment is what will be covered by Dr. Rishi in the next lecture. Then all of us, when we faced with complications, what we need to do is have a proper attitude. And probably all of us should rest, have proper nutrition, and make your body fit and be ready to face such complications. And if you need know the knowledge why these meeting lectures are important is, if you know that such things are done in that way, so knowledge improves. That's why we learn when you need it, you don't know. So the attitude again is very important, and we should remain cool and manage yourself first, and then let people know and call for help. It's always helpful to have other colleagues along with you. And remain calm, control, kind, and open to communication, be it from technicians to our sisters. Do not agitate, do not become restless or panic out of it. Out of control, you tend to do a lot of unfortunate things again. And then always be open to communication. Then the perforations, I think, is already dealt in detail, but I'll show you one or two case examples. These types of classification is already shown. So also it is important is how to prevent perforations from happening. It's always important to learn those. And patient factors, especially females, elderly, frail patients. And then you need to be more careful. And presentations of acute MI, ACS, again, tend to have more complications than chronic stable angina. Lesion factors, calcific lesions, tortuous lesions, tapered vessels, bifurcation, that's where we tend to get into perforations. And another very important material to balloon selection, or the coronary artery to balloon selection, is very important. 1:1, never go more. Some people have ended up with perforation taking 3.5 balloons in mid LADs or distal LADs. That is not permitted at all, and that is not acceptable. And then cutting angiosculpt balloons, or one of those calcium spicules there, even if you're unfortunate, could lead to getting into trouble. And once you land in trouble, one more important thing which you need to decide is never remove the balloon totally out of the guide catheter. Always check with a puff before you remove the balloon out, because if at all you have some problem, we can immediately take the balloon inside and then occlude it, and that will save time. And the hydrophilic wires, slippery wires, again, there's good wires, Fielder XT type of wires are good, but especially when the distal wire perforations happen more commonly, so you have to keep one of your assistant to hold and control the wire not to go too deep in. Stiffer wires, the CTO wires, again, have more tendency to get into trouble, and when you're trying to manipulate and get into it. So these are some universal algorithms of coronary balloon which are already covered, but again, this balloon inflation immediately, again, without removing it is very important. So when a patient is stable, you follow different types, and patient is totally unstable, you follow different type of management mechanisms. This type 1 perforations, Sir has covered already elegantly. I'll show you one or two case examples, which actually this sort of pressure is coming, you be careful. Whenever this also happens, whenever anesthesia colleagues are giving too much of sedation, patients gets into deep sort of Chine-Stokes type of respiration. So, but this sort of pulses, paradoxical type of arterial pulse tracing, you should immediately pick up that something is wrong with the patient, and then that's where we tend to get into trouble. This is a type 1-2 type of branch wire perforations, which has happened in one of these patients. This is the Fielder XT support. It's very good to cross, but if you're a little careless, then the main vessel went in all right. The side branches also, you could get into trouble. So we concentrate on the main vessel, but the side branch also could develop. And you have to be careful in assessing. You see this carefully there, the side that contrast hanging started there. So you need to be careful. Initially, the procedure was over, but later on, the patient developed hematomas and in the post-procedure ICUs. Then we had to get her back and did tamponade cardiac pericardiocentesis, and then patient was stabilized. That sort of distal wire perforations you need not have immediately, but you could develop it in the post-ICU. That's how the immediate post-procedure echo monitoring is very important, especially with wire perforations. Type 2 perforations, again, depending upon stability of the patient, you decide about this thing is again covered. The flow charts are covered by Dr. Ashekar. Just show, I think, the example. Covered stent implantation, again, is very important. All of you, I think you should have the covered stent in your shelf. Without that, you should not be practicing interventional cardiology, I feel. Sometimes only graft master stents are available, but papyrus, which is a good stent, which can go through 5 French, is not available. All of us recently decided to ask the Biotronic people to make it available. This double guide technique, the ping-pong technique, is what is already shown by Dr. Ashekar. It's very important not to lose time. One of the other colleagues can get into through the other femoral artery and then take the catheter in. And the initial balloon can be used to inflate and prevent the worsenings happening. And later on, another balloon covered stent can be taken to the second guide catheter and deliver it immediately so that you could seal it immediately. This is what I was mentioning. The graft master is commonly available, but very difficult to track. Sometimes it could be difficult. The papyrus stent is very easy. I hope the Biotronic company makes it available for all of us. We said unless you get that Arcido stents, we won't use. So they agreed. Their country manager recently said they'd make it available. The cost was the government was paying only 8,000. That's what the concern. But you can always pay and get it on shelf because that's a great life-saving thing if you have it on the shelf. Then another thing is regarding the delivery, that regarding the usage of second guide catheter ping pong. The cartoon shows that. This is a perforation. We see such sort of ghastly appearances could happen, and then immediately sealing it and then taking. Sometimes, if patient is stable enough with only wire perforation, still you could complete the procedure if patient is again unstable. Some of these material embolizations, sealing by coils, again is covered. One of the case example is whatever materials you are comfortable with, you can use it. If nothing is available, the reverse end of the wires or some sort of clotting which you make in the cath lab also could be injected. The occluding a vessel is not a problem. Opening is a problem. Whatever you push it, coil, fat, clot, anything, you can push it and you can occlude the vessels. So this is another patient where he had a CTO type of lesions. We had initially the crossings happened, then patient wire perforation happened. But sometimes if patient is stable enough, the sort of appearances, but still you could finish the procedure successfully with the stent, and that could help in sealing. So depending upon what is the status of patient, you decide. Never panic totally, and then if myocardial staining is happening, if patient's hemodynamics are still under control, you can sometimes safely finish the procedure, and then patients might do all right with that stent. Sometimes could seal those minor things which is happening. Other important problems, which is equipment loss, the stent loss, or under expansion of the stent. Under expansion, we see it very commonly in a day-to-day practice. That's what I will show you one case example. I was mentioning in the discussion. Don't deploy the stents unless you have proper bed preparation. This is a 64-year-old female presented with unstable angina and had a history of right hemiparesis. In the COVID times, recovered from COVID, had a triple vessel disease, advised surgery, because in view of recent history of hemiparesis, and surgeon refused to operate, and heart team discussion, they were referred here. Only good thing was creatinine was normal, LV function was normal. See this sort of long segment triple vessel disease everywhere. There is a long segment calcific diseases. RCA also had disease. These sort of things commonly come outside. They tell for surgery. They come with CDs to us saying that they want to avoid it. So other things are done. Oh, I don't know what happened. So just playing. Some message came and stopped. We'll work here. We'll proceed further anyway. Then this, initially we did preparation, we thought it is done, and then we went on to deploy the stent. What is happening? Complication is happening in presentation. Anyway, we'll go. It's not coming. This is what is the picture. This is where you can use the stent boost. Initially, we took the stent after we thought that the deployment is done. See, such a long stent, 38 mm stent, we could place it. Then after that, you see, not coming. Are you able to see this pointer? No. Not coming. Can you change the battery and give? Okay, then this is the stent area. I think you can see it clearly there. The stent is under expanded there. Then that's where the OPN balloons come a big help. What is recommended is, I don't know what is happening. When it's projected, some message comes. OPN opened at 40 atmospheres. So what we need, we will be worried always to take into higher atmospheres, but keep the size under control. So don't take a bigger sized balloon. If the artery is 3, then probably you'll be restricted with that 3. Yeah? No, it was playing initially. Anyway, so these are the still pictures. Once it comes, it goes. File is missing, it shouldn't come even once. There's something it is showing. Anyway, we'll see. Then we'll move on. So finally, I think we could manage. We did. We could get a finally good result, and then we did imaging too, and the final result was good after 40 millimeters atmosphere dilatation with a OPN balloon. So that sort of under expansions do happen if you don't prepare the bed well. So in post-procedure, we did IVUS and OCT, and then areas were quite good. So this sort of things especially happens when the calcium nodules are projecting from one side. Whatever you do, they don't expand. Orbital atherectomy is one where people are trying in these areas, again, depending upon thickness and grading. Again, as I said that, IVUS and OCT. Then we decide to do shock wave, and if it's only fibrophotic plaque, it's okay, but calcium, the more it is, we need to prepare the bed well. So the approach to calcific disease, if you see critical stenosis, no balloon tracking, probably rotablation, and if a balloon can go, then NC balloon dilatations. Then if a mild calcium, it can get away with NC balloon. With more moderate calcium, we take the help of OPN balloons, and deeper calciums, longer calcium, that's where I think with usage of imaging, you know it, and the combinations of it also could be required, like rototripsy, rota, OPN, and then stent. Then IVL balloons also, after initial cutting, so you need NC balloons of bigger size to inflate and make the lumen better before we take the stents in. So the bed preparation is most important, especially like in RCA. Otherwise, you land up with stent under expansion and troubles post. Then another complication after stent under expansion is stent loss. It's like when you are dealing with a poor vessel preparation, again, calcium, tortuosity, especially some of these later generation stents which are very thin, and you take the stents inside, but you're trying to position it, that's where the balloons come out of the stents. Especially it happens in few of the Indian company stents too. So stent loss, once you junior scholars saying that balloon is not, came out, the stent is not there, you should check where is the stent lost. It could be happening at the end of guide catheters, it could be dislodged totally, and then sometimes you could see stents elsewhere. So difficult stent delivery, again, it could be because of poor guide support, inadequate lesion preparation, tortuosities, and bed angles. So those are the causes for it. And you should always see what is the cause, why, what is happening. Most probably it would be difficult, inadequate stent preparations, and trying to push the stents, the tortuosities, and then that's how you get into deformed stents like this, and then stents could get lost. So depending upon where the stent lost, then you decide your stent modality of how to tackle it. If it is some small peripheral vessel, even if it is there, it's okay. But sometimes it get lost in the left main, that's where we could get into trouble. Stent retriever, some of these techniques called with the balloon technique, take the distal balloon and get it back. And that's what we did in one of these patients, a distal balloon, and everything stent is pulled back. But you also need to have these snares micro snares. These are not bigger snares in the peripheral. These are micro snares for coronaries. If it's available, again, it will help you. And if the stent is not there, you put another wire and do the wrapping, and then if you're fortunate, you could still get it. But one thing we should never lose is don't lose the wire inside the stent, which is lost. Then you still have, as long as you have the access, still you can manage it. So in one of the patient, we had 54-year-old male patient, again, a lot of calcific disease in a renal transplant patient. Then this patient, we were trying to, again, do the procedure because he had a calcific disease and then see the amount of calcium. We tried to do the bed preparations. And then we took the guideliner through. Another problem when you're taking the guideliner disease, okay, to take it in, but while coming back also sometimes the guideliner, the stent could get stuck at the point of the guideliner, and then the stent would remain and only balloon could come back. So there's another precaution we should take it when you are using guideliners. This is a stuck stent now in the left main. And then luckily then I was called in, then I went in, did a wrapping of the wire, and then I got the stent back with the wire wrap. I don't know whether you are able to appreciate because of it's not very clear. But finally, we could deploy another stent and the patient's procedure is done well. I think these sort of things, if you can happen, and many of us would face trouble in cath lab, I think all of us should be mentally prepared and geared up to tackle such complications. I think we can have some discussion. Dr. Rishi, did he come back? He'll show some more cases of embolized material, not only coronary and even outside. Thank you again for patient hearing. Any questions or comments any from the audience or things like that? Otherwise, we'll play some quiz till Rishi comes. Can somebody check where is he? What did he reach? What time was it?
Just to begin the discussion, Kumar and Rajshekhar, when we have
Sorry, sir.
When we have deployed a stent properly, and then you realize that there is a perforation, should we reverse heparin or no? After a proper deployment of the stent.
Yeah, that's a very important point, is always a dilemma. You can manage without doing that, it is always better. But if it is continuously not stopping at all in spite of putting the covered stent, that's where we tend to reverse it. But we don't do it totally, we give half reversal. But if it is more proximal, we are always worried. Give it. Tend to always try to see whether you can avoid it. But if it continuously is leaking, then that's where we are forced to give half this heparin reversal. But it's a wire perforation, distally, you can safely do it because anyway it would occlude, there's no problem. You're occluding the vessel with pushing some material, then definitely we give a reversal there. But only vessel in the proximal perforations, I think that's where I think we tend to give half heparin. And other thing which Rajshekhar sir mentioned was guide catheter perforations, guide catheter ruptures of the vessels. I think in today's era with stents, I think sending such patients for surgery is very rare. Most of the times, we'll be able to tackle patch up with a stent. And even though you may not get a perfect result, but immediate danger, surgery in emergency is a not easy thing. So patient can be stabilized. If at all some problems happen, then it can be seen later. But guide catheter-induced dissections, nowadays we very rarely send patients for surgery. Only total massive perforations, and irrespective of putting sometimes a covered stent to seal it off. But if that is not happening, that's where I think we might need help of surgical colleagues. Other thing where sir said is graft post-CABG patients. There's a graft anastomotic perforations where there's no way you can control extrathoracic structure leak. That's another area where I think we could need help of surgical colleagues. But by and large, guide catheter-induced dissections, I think we have not sent any patients for surgery. Philip?
So, protamine, when there is a perforation, is a very controversial subject. But now it is very clear that once you are inside the coronary, say you have put a stent and you see a perforation, your wire is there, Now you are using a balloon, maybe 3.5 stent and 3.5 balloon to occlude that segment. And majority of the times it seals, the perforation seals. While you are doing all this thing, protamine should not be there given. Protamine should be given only when all the gears are out. If you have removed the wire, balloon, everything, and we are done with, then only protamine has to be given. Otherwise, it will clot, and whatever the chances of the patient would be for survival, that will also be lost.
Perforation, he might die of acute stent thrombosis. So try to correct perforation without reversing it, unless you are forced to do it. Otherwise, don't panic. Continue with your heparin. Don't give protamine very loosely.
Protamine is not going to help anyway, sir. If the perforation is still leaking, it has to be mechanically treated.
It is stent thrombosis or in-stent restenosis. The wiring has to be careful about that when we are wiring the. So a word on that will be useful for the. If you can shed some light on that.
Any questions from the audience?
Your question was on instant restenosis or?
It is instant restenosis or thrombosis. Ultimately, you are going to wire that. So the wiring is a very crucial part of that because most of the time etiology may be malapposition in the or under expansion. So you will be negotiating through that.
Yeah.
One has to be.
If it is happening in an acute situation, sir, that problem is there. But if a patient is coming as late manifestation, generally that worry of a stent going through struts and artery doesn't arise because it gets fibrosed. In acute stage, yes, that could happen. So that's where we tend to see with the balloon tracking and see how if the balloon is going easily. By and large, it will be going through the stent correctly in the lumen, not between the struts and artery. If you still have any doubt, you can always, that's where I think imaging helps to see how is the wire course and what needs to be done further. But if you don't have imaging, at least by tracking a balloon, especially NC balloon, if it is going, by and large, it will be through lumen rather than luminal. So that way have some idea. But one of the important reasons also we have seen is GP2B3 receptor blocker, those Sandeep mentioned, we use it very, very less common. I don't think not using it is a cause for, not using antiplatelets properly is definitely a cause. Suppose by inadvertently people have forgotten to give ticagrelor, then we have had some instances, then they check immediately. Now we have luckily cangrelor also available. Immediately you can give IV cangrelor and manage it. But antiplatelets, yes, immediately that is very most important. And thrombosis happens in front of our eyes if it is not by inadvertently missed out. So that is another very important reason. And how many of you sitting here have faced with this problem of stent thrombosis? I think all of us, because if we have not faced such thing means that we have not done enough. Though it is much, much less in today's era compared to what we used to face before, but it still happens. And some of this in clopidogrel era, it used to happen more because of clopidogrel resistance and things like that. That's where ticagrelor greatly has an advantage. And that's how the usage of ticagrelor has picked up significantly. And that's also very important along with giving high-dose statins. And then probably, if you are too much worried about bleeding, then we are nowadays decreasing aspirin, stopping early. And that's where that helps in a long way to prevent complications. I think, after the stent gets thrombosed, a lot of thrombus material is there. That's where I think people still use GP2B3 receptor blockers, especially like tirofiban is very frequently easily available. Integralin is not there, and Riopro is also gradually fading off because of less demand. That all happened because of better antiplatelet drugs.
Suppose a stent has embolized and it has gone in profunda femoris. What are the options do we have?
Both operator and patient needs to be lucky. Okay. So if you're fortunate enough, most of the times human body is great, nothing happens. But always, if possible, you always try to get it out. So if you can manage and get it out by passing various wires, other things, you always try to do it. But one word of caution, in the process of getting it out, then you could injure the vessels. So that also need to be kept in mind. How you are getting the balloon stented out, embolized, that also becomes important. So you protect the other vessels happening outside and then get it out. Most of the times what happens is it comes up to the sheath, and in the sheath it gets stuck. So that's where we tend to pull out everything and then apply manual pressure And Master of Complications Chair, sir, has come. We wanted you to deliver this talk, sir, but again, in absence of you, I just delivered that. I think, yeah, you're okay. Thank you. So that's how I think we have been live streaming also this. That's what sir is telling, that he is listening to the talk. So most of the times we remove it comes till the sheath, and till the sheath we remove it en bloc and hold pressure. And then RL, sometimes you can change it to a bigger diameter sheath and then try to get it out. That also is sometimes possible. Okay, that's ready. I think, no, sir, your comments.
So one important thing, while I was listening to Dilip when he was saying that if your gears are in, then you should never reverse heparin.
Yes.
One exception. That exception is, recently there was a conference on complications which happens in collaboration with TCT in US, in New York. And one CTO case was being presented. The operator was able to take the knuckle deep into the distal RCA and perforated the RCA 2 places. This patient was a post-CABG. And finally, I'll just cut the long story short. Finally, the operator, as we are in the cath lab, we always want nicely flowing artery, no stenosis. But sometime in an occluded artery, if you create a perforation, the goalpost is different. Normally you want zero stenosis and TIMI3 flow. But in an occluded artery, if you get into trouble, your goalpost has changed. You want 100% stenosis and no flow. This is a situation in which your gears will be there in the coronary artery. You will reverse heparin, ensure that everything is clotted, and then you will come out. And as far as aorta-ostial dissection is concerned, two more important things. If you have aorta-ostial dissection type 3, it is extending more than 4 centimeters into the sending aorta. Call for surgical help. 2, if aorta-ostial dissection from right coronary is spreading towards left, sometimes you are able to handle it with stent, but many times this will be associated with AR. Call for surgical helps. If aorta-ostial dissection has significant pericardial effusion, you will not be able to seal it with a stent graft. But if you have a right coronary artery aorta-ostial dissection, no pericardial effusion, no extension for more than 4 centimeters, no AR, not extending to the left coronary artery, you can seal it with a stent protruding into the aorta.
I think as more discussion can happen, request also all of you to, I don't know, many of the smartphones have this Kahoot app. Go to app stores and download this Kahoot. We can have some fun in the quiz and some of these questions, because you people are not coming out voluntarily. I thought at least this way. India, somehow we have this inhibition of asking. So this way you can participate anonymously. Please download this Kahoot app, this K followed by this exclamation mark. Go to the app stores, both in Google or Apple, download this please. Then we will have some quiz based on it. Sorry sir, you can, if have further questions, we can have it. Otherwise, how this works is, I'll just show you. Coming. Then when we start playing, it generates a number will come, and that number you need to enter. All of you, if you have that, download that Kahoot app, then only we can go. So it comes like that. Then you can start playing. And answers, you can come like this, right? So it will be interesting and fun if you want to do it. So probably before that, we have to download it. We'll give some time for you, 5 minutes, to download that Kahoot app. Then only you will be able to enter the pin which we generate here. Okay? Apart from before, people are, while doing it, if you have any doubts and Rishi comes anytime, you can go for his talk also. At least about 15-20, if you could download it, we can start. How many of you have this app now? Okay, at least whoever are there will do it. I'm also learning. I learned this from my daughter, who's in MD General Medicine. Because first we should go to generation of pin, I think. Give me 1 minute. Ready? Yeah. Directly going, we have to generate pin first. 1 minute. Meanwhile, anybody has any other comments, you can see. It was coming when we were practicing. Now, yeah, something like that. Bit, we should close and directly it is going to, it's not getting pin. I think now let us try this. This is post-CABG interventions. I was trying to go for imaging, some challenging. There are some questions related to graft intervention, which we unfortunately didn't discuss. This is a pin, I think all of you can enter. Got it? Can I go ahead? This is a new pin. Let us try this. 0860 6800. 0860 6800. Okay. This post-CABG interventions, the questions are regarding that. Venous graft occlusion, pre-discharge. How much percentage it is? You can click on one of it, 10%, 20%, 80%, 50%. After surgery is done, before the patient gets discharged, how many percentage of venous grafts get occluded? So So that's, some of you must have answered right. I didn't get, people who have logged in, I need to get the numbers here. I don't know if I can get. Surgeon, strength of the surgeon is bilateral lima, radial artery and SVGs. What is the answer here? I think all of you are not able to play, or is it coming? I don't know. Yeah, it's not live. SVG intervention should preferably have what type of material definitely needs to be taken. NC balloon, Iron Man. Rishi, we are waiting for you. I am doing some time pass before your arrival. Please come. Then probably spider is definitely need to be taken before for SVG intervention, right? I think if he's ready, we'll go to his talk. We'll just finish this. Then another thing is the native vessel intervention is always preferable over graft intervention. Is it true or false? Obviously, many will know it. So I don't know. Some people have logged in. I think 5 I am able to see here. More of them are there. GP2B3 receptor blockers preferable to be used in graft PCI. Is it true or false? I was just mentioning. Generally nowadays we use it less commonly and more so in graft PCI. We don't use it that commonly. So this analysis, it shows who has got how many points here. I think whoever is finally won, I think. 3505, somebody has put K as name. Don't know who is anonymity maintenance. They'll get some prize if you tell who is K. Anyway, I think one small other thing post CABG I was not interested. Actually, I was interested for playing this quiz in imaging or stents. Somehow it is not happening. Yeah, are you ready, Rishi? We'll go. We'll stop this. Come, you call them. Connect. You can remove it.
You don't have video?
Very good evening to all of you. I was just discussing with Professor Trehan that it's blasphemous to give this talk when he is sitting in the audience.
That's what I told.
Because I was thinking of asking you to shift it to another talk, but you know, we've all seen exotic cases shown by Professor Trehan over many years. So I guess most of the audience are trainee cardiologists and DMD trained cardiologists. So I would be speaking to you about a very, you know, kind of a nasty thing that can happen to all of us in cath labs, and that is, what do we do if our stents get embolized? You know, we can talk about other things getting embolized and snaring them, but let's stick to today for only stents getting embolized. You all must have seen it happening in your cath labs, and when it happens, it sends, you know, kind of a emergency panic button rushing, and people try to do all sorts of things to get them out. And mostly are ad hoc procedures that they do depending upon what has happened. But let's approach it in a little structured way, and let's approach it with various case examples of what could be done, what could not be done. And of course, we can take experience and help from all the senior interventional cardiologists about how they would have done. So remember, there's nothing great about having a complication, because somewhere it proves that, our assessment had been wrong. So accidents are avoidable, and it's much better to avoid these complications rather than to fancy them and showing them later on that how I overcome this complication. The first thing is, how do we avoid these complications? And the common predisposing factors for all stent embolizations would be very limited. You have not prepared the lesion well, so you are struggling in delivery of the stent, and in your attempt to bring it back, it embolizes. You have under-assessed calcium spurs, and this have led to the stents getting locked there. You have underestimated the angulation and tortuosity of a lesion. Of course, everything going about that you're not able to deliver the stents, and in your process of bringing out those stents, you have really embolized them. And we'll come to what are the common pathophysiologies for the embolizations, but these are the common predisposing factors: angulated lesions, extreme tortuosity, long, difficult to deliver stent platforms. Some stent platforms are more deliverable than the other stent platforms. So if you are anticipating a problem, for example, a highly, off-course angulated circumflex, please choose smaller size stents. Please choose stents that are highly deliverable rather than using a 48 millimeter, stents that are known to embolize. There are some platforms that are known to, kind of difficult to deliver stents. And of course, one of a very, very important predisposing factor that all of you have to remember is, while you are attempting to bring the stent back, non-coaxial, shape or position of your guiding catheters. And we all will come to this, all these things with the help of the case examples that we'll be seeing right now. So these are the predisposing factors, but stents will embolize in one of these final patterns. Your stent will either get stuck in the lesion, and that would happen when you have not prepared the lesion well, when there is a calcium spur, and it's got stuck in the lesion, and as you pull out the balloon, the stent gets stuck there, and it can't be pulled out. The other more common etiology is that you have pulled back the stent, you are trying to get it inside the guiding catheter. The guiding catheter is not coaxially aligned. In your struggle, you have flared up a few stent struts in the proximal portion, and those stent struts tend to get, stripped off the edge of the guiding catheter. And all these pathophysiologies, non-coaxial alignment of the guiding catheter, the flaring of the stent, you're trying to pull too hard, and all these things can lead to your stents getting stripped at the guiding catheters. And of course, there can be a situation when you have not exactly embolized those stents, but the proximal edge of the stent, either on a balloon or off the balloon, has now completely flared up, and you can't take it back in the guiding catheter. So you'll have to do something, because if you can't take it back in the guiding catheter, it will not go in the sheath either, and it will get embolized, if not in the coronaries, in some other arteries, or more commonly in your radials or your femoral arteries. So these are the final patterns. So you have predisposing factors and you have patterns. When you know the predisposing factors and patterns, you can take steps to avoid them, and we'll come to these case examples. The structured way to approach them is to have this idea that whether when your stent is embolized or you can't pull it back in the guiding catheter, is it still on the wire or not? Because that would make a lot of a difference. If it's still in the wire, if it's still in the coronary arteries, you can take smaller sized balloons and flare them up. If it's just protruding in the left main, you can actually take some balloon and push it back. You can try to retrieve them by snares, by entwining of the wires, or by taking a balloon distally and try to pull it back, although that leads to more nasty things than solutions. But if the wire is free floating, if the stent is free floating and you have taken the wire back, you have also the wire is off the stent now, then you are led with few scenarios. You can either snare it, or you can try wire entanglement and pull it back, or if it's still in the coronary arteries, then you can crush it with a second stent and have 3 layers of stent 1. So these are the various scenarios. But so remember as students that if you are struggling with your stent and if there's some anticipation that the stent might get stripped, be very, very cautious in not trying to pull back the wire completely. If you have wire, you have many, many more options than if the stent is completely lost off the wire. In rare scenarios, we have sometimes threaded a wire in an embolized stent end to end in a high magnification, but that again is something that is fancy work, not an everyday case. Of course, then it's a location at which location your stent is embolized. If it's within the lesion, it's around the lesion, then you are a little safer. But if your embolized or your flared up stent is now hanging in the left main, that's a problem. Try not to do a lot of fancy things there. Try to bring the guiding catheter, wire, balloon, and the flared stent assembly back into a larger vessel like an aorta or a subclavian, and then try to play around with it, because if the stent is flared up and if you struggle too much and try to bring it in your guiding catheters, it is flared up, it will not come in the guiding catheter, it will get stripped at the left main, and that would be not a good scenario to have a completely embolized stent in the left main. So the location of the stent and whether the wire is still in the stent would have a bearing on what are the various possible options that we have in terms of managing solutions. Let's look at scenario 1 based upon whatever we have learned till now. Simple looking circumflex, nothing fancy about it, pre-dilated with a 1.5 balloon, and you try to take a stent across, it will not cross. A common mistake, avoidable mistake. You should have prepared the bed better. And in your effort, trying to pull the stent back, there was some malalignment of the guiding catheter and the stent, and you see the balloon completely got stripped, the stent got stripped of the balloon came back, and you have a free-lying stent, but still the wire is intact. The wire is inside the stent, so you have more options. You can take, because this is a scenario where it's just hanging in the left main, you can take a smaller size balloon, try to push it a little bit in the circumflex away from the left main, and then you can do sequential balloon dilatations to place the stent in the proximal in the proximal circumflex, and then you can complete the case of distal by taking another stent across the circumflex stent. So underestimation of the lesion, not preparing the bed well, absolutely type A sort of a lesion, but still you had a complication. Remember, many of these complications actually happen in apparently simple looking cases, because that's the time when we are off guard. So we have to treat every lesion with respect and not try to kind of underestimate the lesions and take shortcuts in doing PCIs. So you can take the second stent and you can get away with this problem. Now scenario 2 is a little more fancy. Again, you had an acutely occluded circumflex artery, and you had some intermediate type of a lesion in proximal circumflex. Nobody would care about this lesion in presence of a totally occluded artery. Again, you pre-dilated the lesion, but the balloon size, you see single dot, so it's a single, it's not a large size balloon, it's a 1.5 at the maximum. So you try to, it's an acute coronary syndrome, so you just want to make some space, and then you try to take your stent up, and it would not cross the proximal lesion. So what are the mistakes? The mistakes are not assessing the curve and the calcification at the proximal circumflex, and under dilatation of the distal septal, and the stent will. So what happened here? There was no stent embolism at this point of time. You just couldn't get it across. You did a lot of fancy things. You did smaller balloon dilatation. It will still not cross. You took some guide liner, buddy wires. And in that process, the stent came in and out of the coronaries, maybe 1 or 2 times. Finally, when you were able to cross the stent, nothing fancy about it, it will just not inflate. You keep on inflating the stent and it will not inflate. Can anyone of you guess what's going on? The proximal edge of the stent has inflated, but the pressure would just not build up and it will not inflate further. The distal edge the mid to distal stent is firmly attached to the balloon. The proximal stent has a little bit opened up. Can anyone of you guess what is happening? You just can't inflate the stent. You just can't build up the pressure. It will go to 4, 6, but it will not go any further. If you notice the small branch here, there has been a perforation in the stent balloon, and the contrast keeps on, and this keeps on leaking, and it doesn't allow the balloon to inflate fully. So as the proximal edge of the stent has got flared up, but the distal edge of the stent is completely wrapped around the balloon, you try to pull it back, so you just can't strip the balloon here. Initially we thought that we can strip the balloon and take smaller size balloons and kind of do our work, but because the stent is still sticking on to the distal edge of the balloon, as you try to strip the balloon, the whole stent and flared assembly came back in the left main. Now this is a dangerous scenario, because if you try to struggle a little bit more with this guiding catheter, and if you try to pull the stent back, the proximal edge of the stents are flared up, the stent will get stripped in the left main of the balloon, and you will have more difficult times solving. So it's better then to bring this in a large size artery. When you begin the large size artery, remember the balloon is still there and the wire is still there. If you pull it back too much in the radial, you will lose the stent in the radial artery. If you try to snare it by a femoral artery, femoral route, you will be catching on the wire, balloon, and the stent together. So again, it will be you will be locked at both the ends, and it will be a difficult scenario. So what you can do here is catch onto the wire, use this wire as a rail to push the sheath of the snare up, take it very close to the, very close to the stent. Position your snare up closely. Once the snare is in the position, you can do a calculated, stripping of the balloon. You can see the calculated stripping of the balloon. So balloon is now stripped up, but at the same point of time, the stent metal is still on the wire. You just can't catch it now, because if you catch it now, you'll be catching the wire and you'll be holding the wire from both the ends. So then you try to close the snare and make a very small loop, and when we are reasonably sure that you are not going to miss the stent, at that point of time, you can pull back the wire also, and you see the wire is being tugged back, and the wire is. So now when we were very sure that we are not going to lose the stent, we pulled back the wire from the radial and caught it in the snare and pulled it back. But one mistake we did. Whenever you have an opportunity to go femoral or any other axis and try to pull back the stent, try to take a large size sheath, as large as possible, because here again you took a 7 French French sheath, and there's a chance of stent getting stripped here also. But it was fortunate that we could take it back, we could take it out. This was the final snare. Almost similar looking scenario. You could complete the almost similar looking scenario. The stent has now come back into the radial. You try to pull it back in the radial, it will not come in the sheath. It will somehow get caught up in your radial artery, and then there are other methods to take it out. So what you can, it doesn't look too much flared up at this point of time, but we tried to entwine it with a wire and take it back. Not successful. A JR going through femoral, and the wire of the stent is now pushed into that JR, and then the stent shaft is also pushed. We try to trap the stent in a second balloon in the JR guiding catheter, tried to pull it back. It will not happen, but now it has caught onto the wire, so we can do an escort guiding technique sort of a thing. You can push the guiding up from the radial, and you can pull down from the femoral, and then you can catch this stent like in the previous case, and you can pull it out. If nothing works, it's stuck in the radial, then probably what you can do is you can surgically take it out, and that's the one way to look at it. This incision is actually too big. You can take it out from a much smaller incision also. So many of the things, one of the case that it's not being shown here, and I would like to discuss with if it's given a time Dr. Trehan. Now, this is the same scenario in which the stent has got stuck here. So I feel that when we try to pull it back and the stent always gets lost, and even if we take the guiding out and try to pull it, the spasm of the radial artery will catch on to the stent and would take it out. But between that spasm, that closure happening, in this case, we just kept the flared stent right at the tip of the guiding catheter, right at the tip of the guiding catheter. And in a fraction of a second, we took out the whole assembly together. As we took out the whole assembly together, before the artery had a chance to collapse on the metal, it came out a little bit, and we could actually catch on to this with our fingers without giving any incision and take out the stent right through the skin. We confirmed it that it's not the artery that we are pulling, and we could pull the stent out. But that has to be done in a very, very swift motion, right at the ostium, right at the mouth of the guiding catheter, and you can completely pull it back. So any comments on that, sir?
Human body is great, Rishi. Sometimes endothelium comes, strips off, nothing happens. Still patient's radial artery is patent.
We've had similar issues even at the groin. But I think at 2 to 5% radial will block off.
Yeah.
If you have left a stent in the radial, just don't do anything. According to me, सर्जन को बुलाना बिल्कुल गलत बात है. कसाईयों के मोहल्ले में कभी मरीज को भेजना नहीं चाहिए, याद कर लो आप. The moment you call surgeon for just trying to get your radial back, anyway, the kind of surgery which is done in such cases, I don't know whether you really followed up these patients or not. Stent is out, but what happened to the radial? It is possible with so much of trauma, the radial will be knocked off.
Yeah.
And if the radial was to be knocked off and everything was sterile, leaving a stent in the radial is not going to do anything. Practically nothing. According to me, I will be less brutal in handling it. At the groin, the story is different. At the groin, the story is different. As far as your second case is concerned, when you were struggling at the brachiocephalic, I was very uncomfortable. That's not a playground.
We can break it down more.
Yeah, that not at all a playground, because there you can have a problem and you can shoot it up into the brain. I think you should have you should have bobsled things. Yes. Shift the playground, push it from the radial, let the things come down to the descending aorta. We can go for a cup of coffee. Let a junior man do the task.
Absolutely correct.
And as far as trying to retrieve a stent is concerned, the moment, I think that point was very well said, but to be hammered again. Catching a stent is not a big deal, but getting it out is sometimes such a big deal that it becomes hell of a problem. So once the stent is out of the coronary, कोई problem नहीं है. Have a cup of coffee, discuss with somebody, आराम से काम करो. और उसमें सबसे important चीज है, the groin sheath. All of us know how to close the groin nowadays with proglides. So 8, 9, 10 French लो आराम से, कोई issue नहीं है बिल्कुल भी. 10 French में के अंदर there is absolutely no need for even having a proglide. 10 French sheaths, simple compression, they will heal very easily. But if you have a 10 French sheath and if you have got a stent, because stents, the moment you catch them with the snare, they get too much disfigured. But if there is a big receptacle in the form of 10 French sheath, they tend to come back very easily.
Absolutely, great points. That's a very, very important point that I missed, that you should not be playing around. That's the wrong thing. You should not be playing around in your subclavians and your brachiocephalics, because then in the brachiocephalic, the stent can embolize up. It's much, much safer to bring it down in the descending aorta and to do all your fancy work that you need to do. That was done in the third case, but not done in the second place. Yeah.
I think one of the patients...
Query to you, because I didn't answer your question, because when you lost the stent in the circumflex and there was a stain in the circumflex, in fact, the stain was not only in the OM, there was a huge stain in the intramyocardial stain, as if let us say there is no stain, then what are the differentials?
No staining in the balloon and the pressure will go up.
No, same, whatever is happening to you is same.
Right.
But there is no stain as far as OM is concerned. You're not seeing any OM. Then what are the possibilities?
Means it's after the perforation.
Yeah. No, the same case,
Yeah.
absolutely same thing.
Yeah.
But your proximal balloon inflated in the circumflex. Distal balloon did not inflate and the stent is there only. And you are not seeing any contrast in any of the branches.
A clot causing a lock in the, maybe we have pushed something in the clot or
No, we have had many events. Like this is not one. There was a time when my hospital did not have good quality stents, and I had opportunity to take out 31 stents in 2 months. So that is tremendous, and has had all of them. The typical problem in such cases is that in that event, the dye may not be coming into the coronaries. You might have ruptured the shaft of the balloon catheter.
Right.
Then the dye gets out of the tip of the guiding catheter.
Right.
When the shafts get broken also, it happens.
Yeah, then the dye leaks from the tip of the guiding catheter.
The shafts
It's a
get
kind of a
broken.
slow angiogram.
And we also, in one of the episodes, we pulled it, some endothelium of a radial artery also came out.
Yeah.
Nothing happened to the patient, just we applied pressure and applied plaster. As sir said, radial is gone, but nothing happened to patient. Human body that way.
Yeah,
is
I think
solid.
leaving stents in radial is not a problem, but only for, it's very difficult to explain to the patient that's from a medical legal point of view. Yeah.
One more short point, because I had published this thing, I think some 15, 20 years ago in Indian Art Journal when we lost one stent. Similar, exactly similar. But the only difference was my professor was doing an angioplasty to circumflex through radial approach with a 5 French. So he had the courage to do absolutely similar case, and then a kind of a deadlock, same in the brachiocephalic area. So what I feel is that in such a scenario, it is very easily said that you take a snare from below. You must remember that most of your snares, they are 105 to 115 centimeter length. And if you're taking a guiding catheter, which is 100 centimeters, you add about 7 centimeter of your 2E burst. There is very little working space. So if you have to catch something in the brachiocephalic or in the radial, it is very, very important that you first shorten your guiding catheter. If you do not shorten your guiding catheter, you will have a lot of problems. That is why in the business of retrieval, it is extremely important to know your hardware. Otherwise, commonly क्या होता है? वहाँ चले गए, अब ये जा नहीं रहा, ये छोटा पड़ गया, ये बड़ा पड़ गया, ये बड़ा common होता है. You must know your hardware. And as far as hardware of your snares is concerned, especially bigger snares, that means any snare which is 10 millimeter and above, their length of the snare shaft is short. It is not like 150 centimeters. So it is all, and if you have to go from below, it is always good to learn to shorten the guiding catheter, which is a very simple technique. Or sometimes have short guiding catheter on the shelf, that is like 90 centimeter, 85 centimeter, or 80 centimeter guiding catheter. They are available.
I think any questions from the doctors who are there? Huh? Any complication you faced, anything you not discussed also, you can ask. Anybody? Master of management of complications, I would say, not master of complications. Sir is also here. Any doubts you have? Any funny complication you faced in cath lab? Anything? Please, Rishi, you can have. Otherwise, we'll go to the pre-dinner symposium. Please, Dilip.
So I have one or two comments. I think we have learned all along from sir how to manage complications, but some of the complications which looks so dreaded, they can have easy solutions as well. Only if we have proper hardwares with us. So Dr. Rishi used N snare there. It's a large 3D snare. But if a coronary snare had been there, it goes over the wire. So a coronary snare, it's 2 to 3 mm, and it goes over the wire. So it has to go only over, onto the stent. And you just reach there, catch, and bring it to guiding catheter and remove the assembly. So, and also there is a solution. There is a problem where you inflate a stent and balloon is now not deflating. It is also one of the big challenge. And there is also a dedicated catheter made by Terimo. You have to cut the distal shaft of the balloon, and this catheter goes over the wire as well as the balloon shaft, and it just goes over the balloon, and there are some spikes there. It bursts the balloon, and you can easily retrieve the balloon and everything out. So we have got some easy solutions provided we have the proper hardwares with us. So I appeal to all of you before going and seeing these kind of complex patients intervention, you need to have these hardwares with you.
But before you end the session, I think you must compliment Dr. Rishi. Fantastic talk, excellent pictures, and I think he went with the timeline in such a nice manner I have all the videos with me on my phone. Thank you very much for excellent talk.
So just one comment from my side for the beginners. First thing is that you have three techniques. You can deploy the stent. If you lose a stent, then you can try to deploy it, especially if you are on the wire. The second option is to crush it to the side of the vessel, and third option is to retrieve it. So please remember that redeploying is the best option. Crushing is the next best. Retriever is only for experts. So don't try to do unless you really know, as sir said, hardware and other things. Second point I wanted to make was, if you lose material, maybe stent or whatever, torn balloon, etc. If you lose it in the coronary, it's a problem, especially if it is proximal part. In very distal branches, etc., maybe you could just leave them alone. The other thing is losing material in outside the coronary is not a problem at all, unless it can go into carotids or in the pudendal artery. Otherwise, it is not a problem at all. So you can very safely lose material in the aorta, so far as you are sure that it's not going into the carotid. So it's a distal, descending aorta, etc. You can easily lose it. So these were my 2 points.
Are you worried about a pudendal in a female or an elderly gentleman?
So I just want to just one more comment that the ethos that I want to get across is that if it's happened, then of course we can discuss everything. But if you remember that if you are struggling, be it in torsion of your guiding catheter or the stent delivery or your balloons are not going, then use of force is sometimes, the saying is that more things will move in the cath lab by application of mind than by application of force. So if you are struggling, something is wrong, try to think it over, try to have a proper solution for it, because otherwise struggling and trying to overcome it by force or by too much push or too much pull would probably lead to these complications more often than if the procedure has been smooth.
I keep telling fellows, cath lab is not a place to show your power. Okay, don't apply any resistance is there. Don't apply too much power, or you'll produce more trouble and damage. I think we'll have further more discussions during the break, and we'll go to the talk. I think which Lupin is very much interested. One, because the leaders with Ivabradin. Other is they have also launched recently the ticagrelor. These two talks, I think they've made efforts to get us, all of us. I think it is our duty to listen to these two talks. I think both is, one drug is already well established, the other drug is very effective. I think it's very important to have this. And significance of heart rate management with Ivabradin in evolving era of guideline-directed medical therapy in heart failure with reduced ejection fraction patients. Dr. Bhupen Desai, sir. I think they heard you talk on this many times and they requested. I said, most welcome. If sir can deliver this talk, it is fine, I said.
So before we can go into the next session, we would like to felicitate the last session speakers.
Anyway, after this roller coaster ride in the cath lab, I think now let us come back to the ground. The bread and butter of the cardiology. Once you pass your DM exam or DNB exam, life will not be very smooth in the cath lab. Most of the time, you will not get entry into cath lab. The life is very difficult for the interventional cardiologist. So let us come back to the bread and butter of it, and that is the heart failure, which is a growing epidemic, I believe. Number of cases are rising despite the fact we have a good number of good therapy, but still something is missing. Despite guideline-directed medical therapy, heart failure-related mortality and heart failure-related rehospitalization rates are still quite high. So let us discuss what we can do to improve the outcome of heart failure with reduced ejection fraction patients. And the most neglected entity is about, I think, heart rate. We talk about the blood pressure, we talk about potassium, creatinine, and all those things, But we somehow tend to ignore heart rate as an important risk factor in heart failure with reduced ejection fraction. How do we achieve the target heart rate? And are we still there or not? What is the current scenario in India? I'll discuss about it. What is the evolving landscape of heart failure with reduced ejection fraction management and the place of heart rate management in the therapy of heart failure with reduced ejection fraction? And what is the role of ivabradine in this evolving era of the guideline-directed medical therapy? As you can see, that heart rate is an important risk factor in the chronic heart failure, which somehow we don't realize it. And we have a data from the SIFT study, very interesting data. This is the data from the SIFT study from the placebo group who did not receive ivabradine. In SIFT study, there were two groups. One group received ivabradine, one group received no ivabradine, only one placebo. And as you can see this, what is the outcome? Primary composite endpoint of cardiovascular death and hospitalization for worsening heart failure. You can see this here. This is the heart rate which is less than 70, around 70, and this is 87. Look at this. When your heart rate is around between 70 or 72, your outcomes are much, much less. But if your heart rate is about 87, it is much high. This red line represents that heart rate of 87. These are relatively stable patients. Only heart rate is an issue. Similarly, the incidence of first hospitalization for the worsening heart failure. Again, you see, this is the heart rate which is between 70 to 72, and this is 87. And look at the difference, big difference. Similarly, cardiovascular death also increases if your heart rate is high. And how much does it increase? Patient with highest heart rate, that is more than 87 beats per minute, were more than twofold, I'll repeat, more than twofold higher risk for the primary composite endpoint than were the patients who had a lowest heart rate, that is between 70 and 72. So if your heart rate jumps from 70 to 87, your patient has a 2 times higher chance of dying because of cardiovascular death, or has a more chance of going back to the hospital. Heart rate is an important risk factor. Somehow we have never realized about it, particularly in the setting of heart failure with reduced ejection fraction. And this is the data from the real world. Heart rate less than 70 and heart rate more than 70 were compared. Look at this. Mortality increases by 36%. All-cause hospitalization per year increases by 25%. Heart failure hospitalization increases by 51%. Significant number. High pulse rate both at the time of diagnosis and at the time of discharge or at the time of follow-up are very important. And they are strongly associated with the increased risk of adverse cardiovascular outcomes in the setting of heart failure and reduced ejection fraction. Heart rate at the time of discharge, when our patients are discharged, we check his blood pressure, we check potassium, creatinine, and all those things, but we hardly ever bother about the heart rate at the time of discharge. Heart rate at the time of discharge may be a very, very simple measurement to assist in identifying high-risk patients after an acute decompensated heart failure patients. Look at this. If the heart rate is cumulative survival, the least with when the heart rate is more than 90, but it is quite good if the heart rate is about less than 70. And this does not depend on beta blocker doses. These patients are on beta blocker. Some of them received 75 to 50% of the dose. Some of them received 75 to 100% of the dose of beta blocker. Beta blocker, they've received full dose. But still, if the heart rate remains high, despite having beta blocker, he has a less chance of survival, as you can see from this. So, beta blocker per se does not give you full protection. You need to bring down the heart rate. As you can see in this, acute decompensated heart failure patient with heart rate of more than 90 at the time of discharge is an independent predictor of increased mortality at 1 year follow-up, irrespective of beta blocker doses. So sometimes we get carried away that beta blocker reduces mortality by 35%, 34%. But beta blocker, along with that, heart rate has to come down. Look at this. And what is the benefit of controlling heart rate? I showed you that if the heart rate is high, you have a problem. But what are the benefits? So optimal heart rate control improves long-term prognosis in decompensated heart failure with reduced ejection fraction patients. If you see this slides, I don't know whether you can see it or not. If you can reduce heart rate by 30, or maybe a little more than 30, then you have the best survival chance. Composite of cardiovascular death and heart failure hospitalization are much better if you can reduce heart rate by about 30 beats per minute. Same is with cardiovascular death. But if your heart rate is decreased by less than 30, that is say 10 to 20, then you still have a benefit, but benefit is much less. And if unfortunately if heart rate increases, then you have a worst outcome. So as far as composite of cardiovascular death or heart failure hospitalization is concerned, or independent CV death, or all-cause mortality, or heart failure hospitalization, whatever it is, if you can reduce your heart rate by 30 beats per minute, you have the much better chance of giving better life to your patient and better survival benefits. Are we there in India? What is our mean heart rate in various Indian heart failure registries? You can see this. In Asian Heart Failure Registry, Indian cohort had a heart rate of 81 beats per minute. Trivandrum Heart Failure Registry had mean heartbeats of 99 beats per minute. Vedanta Heart Failure Registry had 80 beats per minute. The National Heart Failure Registry had 93 beats per minute. Another registry, that is National Heart Failure Registry, this was ICC, this was national. 37% of patients with had a heart rate of more than 100 at the time of discharge from the hospital. CSI Kerala Heart Failure Registry showed that 32% of patients had heart rate of more than 100. So we have not reached, we have understood the importance of heart rate, but we have not achieved in real life, as you can see from this data. Even after giving beta blockers, sometimes heart rate is not fully achieved. Look at this. Despite treatment with beta blockers, a substantial proportion of patients hospitalized with heart failure and reduced ejection fraction have elevated heart rate at the time of discharge. This is a data from optimized heart failure study. Very good conducted study. Look at this. Patient who had a heart rate, those who received between 50 to 99% of target beta blocker dose. Those who received more than 100% of target beta blocker dose. So even after giving full dose of beta blocker, which patient could tolerate, still your heart rate is above 70. Look at this. This diamond represents the median heart rate. And still, even after getting more than 50% or more than 100%, your heart rate has not come back to 70. You can see this. Of patients with more than 50% target dose, 63% of these patients had a resting heart rate of more than 70 beats per minute at the time of discharge. This is the data from optimized heart failure study. So friends, on top of guideline directed 4 pillars, that is SGLT2 inhibitor, ARNI, beta blocker, and mineralocorticoid receptor antagonist, you need to consider some add-on therapy, particularly when your resting heart rate at the time of discharge or at the time of follow-up is more than 70. And that can be achieved by giving evaporating. And what is the advantage of evaporating? I'll discuss with you. What is evaporating? It's a pure heart rate lowering funny current inhibitor, which is there in the sinus node only. So it has a pure heart rate reducing effect. It has a heart rate lowering properties without any direct cardiovascular effects. It does not cause any decrease in the blood pressure. It does not cause any decrease in the contractility like beta blockers. It is a first in class of agents that can specifically act only on sinoatrial node and nowhere else. It inhibits the funny current of the cardiac pacemaker cells without affecting other cardiac ionic currents. It has a unique pharmacodynamic profile as heart rate reduction. Is not associated with negative inotropic effect or vasodilatation. So it never causes decrease in the contractility like beta blocker. It never causes decrease in the blood pressure. And we have enormous data now. Not only one SIFT study, on spectrum of clinical evidences with evaporating in heart failure and reduced ejection fraction. Look at this number of data which we have. SIFT study, SIFT heart failure with more than 77 beats per minute, SIFT with or without beta blocker, SIFT Holter study, relief congestive heart failure study. Then there are studies with combination of beta blocker or without beta blocker. There are studies of analyzing the effect of evaporating on the heart failure hospitalization. Also, there are studies on the impact of LV function and quality of life. And there are special population SIFT subgroup analysis, particularly in settings of diabetes or in the settings of renal function or setting of renal dysfunction rather, COPD, low systolic blood pressure, LBBBS. So we have enormous data of evaporating now, but somehow it has never translated into our clinical practice. The phenotypic approach in heart failure with reduced ejection fraction patient. It is based on heart rate and blood pressure. And these sort of patients we see in our clinical practice. Either patient has a low BP and high heart rate with heart failure, or he has a low BP and low heart rate, or he has a normal BP and low heart rate. He has a normal BP and high heart rate. Many of these patients have atrial fibrillation with normal blood pressure. Some of them have atrial fibrillation with low blood pressure. Then we have CKD patients. We have a patient who continues to have hypertension despite guideline-directed medical therapy. So situations where evaporating is very, very helpful is these two. Low BP, one which I have highlighted, low BP with high heart rate. These are the ideal patients for ivabradine. And patient with a normal BP, you can also give ivabradine if he has high heart rate. And what these two lines I have put in red lines. Many of physicians continues to prescribe ivabradine in atrial fibrillation patients whenever they present with heart failure and fast heart rate. It is an absolute contraindication. Please do not prescribe ivabradine in setting of atrial fibrillation. So atrial fibrillation with normal BP or atrial fibrillation with low BP is not an indication for ivabradine therapy. It is indicated only in a patient who has a normal BP or high BP or even low BP, but heart rate continues to be high. Those are the candidates which will benefit by this. As you can see from this slide, low systolic blood pressure and high heart rates. I'm sure all of us see these sort of patients in our ICU. They have a higher risk of adverse cardiovascular outcomes. And this was the analysis from the SIFT BP study. Look at this. Patient who had a low BP, less than 150, and high heart rate, that is more than 81. They have the worst outcome. Look at this bar. And those who had a normal BP or good BP, more than 130, and heart rate was less than 75, less than 74, they had the best outcome. So patient who had a low systolic BP and high heart rate, they have the worst outcome, and they are going to benefit maximum by giving ivabradine. Now look at this, importance of low systolic BP and high heart rate phenotypic patients. They are associated with high risk of adverse cardiovascular events, as I told you. And this is the data from Qualify registry. If you assume the risk is 1 in a patient who has a low resting heart rate and high systolic BP, these are relatively stable patients. Low resting heart rate and high systolic. What do we mean by low resting heart rate? That is about 75 beats per minute, and BP is more than 110. Patient who has heart rate of less than 75 and systolic blood pressure of more than 110, they are reasonably safe patients. So let us assume that risk is of 1. Look at the second group. Those who have high resting heart rate and high systolic BP, hazard ratio is high. Those who have low resting heart rate and low systolic BP, it is still high. But these are the worst patients. High resting heart rate, I repeat, high resting heart rate and low systolic BP, hazard ratio is almost 2.5, maybe a little more, around 2.6 or so to be very exactly. So ivabradine along with beta blocker. We all know the importance of beta blocker. We all prescribe beta blocker, but if we somehow forget to prescribe ivabradine. So what are the indications for that? Ivabradine along with beta blocker provides you complementary and synergistic benefits, particularly in the setting of heart failure and reduced ejection fraction patients. As you can see this, ivabradine selectively reduces heart rate. It has nothing to do with cardiac contractility. It has nothing to do with blood pressure lowering. While beta blocker will reduce heart rate, at the same time it will reduce your blood pressure, it will reduce your cardiac contractility, and it will slow down the conduction. So, and when you give beta blocker, alpha receptors are unopposed. So they can have sometime a negative cardiovascular, coronary vasoconstrictor effects, while ivabradine does not have any vasoconstrictor effect on the coronary arteries. And you should start it as early as possible. Reason is, as you can see from this SIFT 2023, this is the latest data, post-hoc time to benefit, as you can see this. The benefit of adding ivabradine can be visible as early as 67 days in a patient with heart rate and reduced ejection fraction when the heart rate is more than 75. All your patients who has a heart rate of more than 75, and if there is no contraindication, you must start ivabradine as soon as possible. The reason is your patient will have a less chance of dying because of cardiovascular death or going to hospital, and this benefit starts coming by the 67 days. Hospitalization for worsening heart failure, benefit starts occurring from 78 days. And these are all hard endpoints. Cardiovascular death, benefit begins at 169 days. Heart failure death, benefit begins at 157 days. So if you delay, you are delaying the benefit to the patient. All-cause death, which is a very hard point of any study. There is no compromise about it. Death is a death. So all-cause death starts declining from 169 days. So you start as early as possible if your patient has a heart rate of more than 75. So heart rate reducing treatment should not be deferred because treatment delay leaves patient at a high risk of events including death. This is another subgroup analysis. Heart rate reduction with ivabradine is effective and improves clinical outcome in heart failure patients across various risk indicators without any safety concerns. Whether your BP is more than 110 or BP is less than 110, it is beneficial. Whether ejection fraction is less than 25% or more than 25%, it is equally beneficial. If your patient is in class NYHA class 3, 4 or 2, it is equally beneficial. Regardless of NYHA class, regardless of blood pressure, regardless of ejection fraction, is beneficial. The benefit is more when your resting heart rate is more than 75 as compared to resting heart rate of less than 75. Simultaneous initiation of ivabradine and arni can be a better strategy to reduce adverse outcomes due to improved hemodynamic stability. As we all know that whenever you give sacubitril, valsartan or arni, there is a small possibility of blood pressure going down. So sometimes we are worried about combining it with beta blocker or something. We start little sequentially, but you can safely give arni along with ivabradine because ivabradine gives you significant hemodynamic stability because it does not affect blood pressure. It does not affect cardiac contractility, unlike beta blocker. So if you combine these two, you will have a significant improvement in ejection fraction by about 12.8%, rather than giving sequentially. If you give arni first and then ivabradine, then your ejection fraction will improve by 9.3% only. Similarly, left ventricular end diastolic volume and left ventricular end systolic volume will significantly decrease if you give them together rather than sequentially. Improvement in ejection fraction, as you can see this, it improves significantly if you give it together. Reverse cardiac remodeling, left ventricular end diastolic volume, left ventricular end systolic volume also significantly decreases when you give it on top of the guideline directed medication. Improved quality of life. This is at the beginning when heart rate was about 85 or so. When the heart rate became around 72 or so, look at this. KCCQ scores significantly improved. So it improves quality of life also. First 30 days, we all know, are very significant after a patient is discharged from the hospital. Ivabradine significantly reduces the frequency of rehospitalization when administered in a setting of acute decompensated heart failure patient at the time of discharge. 30% reduction at the end of 30 days of need for hospitalization. Significant reduction in heart rate with improvement in LV ejection fraction, as you can see in this thing. This blue bar is with ivabradine and beta blockers. If you combine these two, your ejection fraction will improve over a period of time. Your quality of life will improve, your 6-minute walking distance will improve. So to take home summaries, high resting heart rate is an important risk factor in heart failure with reduced ejection fraction, and we need to control it by whatever way you want to give it. Either you can give beta blocker, and if you want to give something more than beta blocker, then maybe you can add ivabradine. So to conclude, there are 2 more slides coming after my conclusion. Benefits of ivabradine in heart failure with reduced ejection fraction is it improves survival, it reduces post-hospitalization, it reduces rehospitalization, it reduces the number of hospitalizations, improves quality of life, increases ejection fraction, it improves NYHA class and exercise capacity, it reduces NT-proBNP, it can be combined with any other guideline-directed medical therapy without any safety concern. So you all know about this hare and tortoise story. The heart rate of hare is 10 beats per minute, and heart rate of tortoise is 5 to 10 years. Look at this next slide. Sorry. So heartbeat is this 10 beats, and heart rate of hare is 180 to 350 beats. And look at their survival. Some of the species of tortoise can live up to 250 years, while hare will live up to 5 to 10 years. Thank you so much. Heart rate matters.
Thank you, sir. We don't want to live so long also, sir. Please come. Anyway, next talk is another great talk, sir. I think you're a very strong believer, and that gives a lot of confidence to youngsters to prescribe this molecule in heart failure. I think now we have another interesting molecule, very powerful, potent, in very value addition in lipid lowering therapy. That is about inclisiran. And let us hear about it, reducing risk among ASCVD patients, focused on newer LDL cholesterol lowering therapy, inclisiran. Dr. Dilip.
Yeah. So before I begin, I would like to share an experience. Yesterday I was in India CTO, and a familiar face came to me. Sir, I am Santosh. You recognized me? Yes, yes. I'm missing out your name, but I can recognize you. I was boss of Subrato. Okay. So I used to sell Rapatha, Ivalukumab. So now what are you doing here in the CTO? Now I have changed to Boston. So I thought it's a genuine reason. Now in the time of inclisiran, someone who was selling Rapatha, Ivalukumab, what happened to them? So on the lighter note, let's begin reducing risk among ASCVD. So when statin came, we all thought, okay, it's over. Now the stenting will be less and everything will be fine. But at this moment, we feel that statin is the beginning. And despite statin therapy, we have a lot of residual risk which remains there. And you can see all the landmark trials like 4S, lipid, care, HPS, VOSCOPS. After the reduction, it does reduce your, increases survival and reduces the mortality. But residual mortality and MACE is still there, and that is also substantial. And this goalpost is ever changing from 100 to 70 to 55 to 40. Now people are claiming 25 or to 0. So the ESC says still less than 55 is the goal for very high risk patient. And what we actually achieve is these are some landmark trials from Europe. 20 to 30% of the patients, maximally they are in targets after acute coronary syndrome. And what would be a percentage going in India? It should be around less than 10%. And LDL is considered to be the risk factor. So now from risk factor, it is considered to be the central factor for atherosclerosis. And that is what there is a hypothesis that if you bring down LDL to 70, if you start intervening at 30, then you are going to live 100 years. So Dr. Braunwald is proposing that you reduce your LDL at the age of 30, bring it down to less than 70, and you just continue, you will be living 100 years. So this is the cumulative LDL burden, which is leading to atherosclerosis, that correlation is very linear and very highly documented and studied. So once we have an acute coronary syndrome, next couple of years are really, really traumatic. You will have again a chance of recurrent myocardial infarction or ACS. First year is very, again, you are at very high risk of recurrent events. And once you get these recurrent events, the treatment is even costlier. So this is a huge burden. It's not only the kind of disease burden, the economical burden to the patient and the society is also huge. And that is where if you cough up money for some drug which is going to reduce the LDL to less than 35, 40, it makes sense. This is our Lipid Association of India, risk stratification and the LDL goalpost. So Lipid Association of India proposes LDL of less than 40 in extreme high risk patient. I am not going in detail about which are extremely high risk patient, which are very high risk. I assume that everyone knows here. And these are the targets. So we right from HMG coenzyme A, we have got ACL, that is a target. Then we have PCSK9 and some other targets in gut. And I will be just concluding by enumerating 10 reasons why to consider inclisiran in eligible patients. So the number one, inclisiran is safe. It is out of the bloodstream in 24 to 48 hours. It acts in cytoplasm, it doesn't act in nucleus, so the cellular function remains there. And it is highly specific to hepatocytes. So there is a GalNAc which combines with inclisiran. It is taken into this hepatocytes, and this goes to cytoplasm. There the destruction happens of messenger RNA. So the nucleus remains functional, and that is why. And it is more specific to liver, which is targeted entry into there with GalNAc. So this is very specific, and off-target action is very less. So this is how this is inclisiran gets into the hepatocytes. There is a GalNAc which attaches there. It leaves into cytoplasm. Then there is a RISC. It combines with the RNA-induced silencing complex, which further goes to messenger RNA and causes the destruction of messenger RNA eventually. Second is suitable pharmacokinetic properties of inclisiran. So it is highly, highly predictable, no drug interaction, no off-target effects observed, no dose adjustments needed in liver dysfunction or renal dysfunction, and adverse events are very, very less. Very easy to give. So unlike evolocumab, you don't have to give twice in a month. It is 6 monthly doses. First dose after 3 months, again dose, and then 6 monthly. So it's highly conducive to administer, and patients are receptive to this. 2 injections in a year. And sustained duration of action of effect of inclisiran. Once the inclisiran gets into some chemical modification, it gets stabilized in the hepatocytes. And the RISC complex further stabilizes that. So it remains there and works for 6 months, and that's why we get a lesser number of injections which is needed. Finally, we have established efficacy and safety, which has been studied in multiple and heterogeneous populations. So we have Orion 9 with HEF heterozygous familial hypercholesterolemia patient, Orion 10 in ACVD patients, Orion 11 and Orion 9. So we have in homozygous familial hypercholesterolemia. So we have diverse group of patients on which it has been studied. So Orion 10, 52% reduction, effective reduction, 54% sustained reduction of LDL over 18 months. And this is in Orion 9 in heterozygous familial hypercholesterolemia, again 48 to 49% reduction. And what about other lipid parameters? ApoB is reduced by 41%, never seen by statin. Non-HDL cholesterol reduced by 47%. LPA gets reduced by 21%. So these are cherry on the cake. So not only reducing LDL, achieving the target, LDL target, we're also working on non-HDL goals, your ApoBs and LPAs, which are highly essential and important. And side effects are comparable to the placebo. There is no inter-individual variability, and this is the Orion 8 extended long-term follow-up at 6.8 years, and that shows that the effect remains there. None of these patients get tolerant, or after three years, the effectiveness of inclisiran is going down. It doesn't happen. So very reassuring. Even at 6 years, you get the same 61 or 58% reduction of LDL. The seventh reason is Indian population, Asian population has also been studied, and we see the same kind of results. And there's a whole lot of studies are in pipeline, be it Victorian 2 Prevent, Victorian 1 Prevent, Victorian Plaque, and we'll be getting more insights. But pooled analysis from phase 3 trials suggest 26% reduction in composite MACE. So it's highly significant. But these are pooled analysis. We are waiting for RCTs for the outcome data. And finally, for myocardial infarction patients, be it acute, be it remote, be it recent, the level of reduction of LDL is similar. Ninth factor, Victorian Initiate trial. Those patients who had more than 70 LDL after established ACVD, after statin directly going for inclisiran, what are you going to get? So you get this thing. So you see here, you can come down on LDL by 60% by Victorian Initiate, strategy than those standard of care, like you adding bempedoic acid, ezetimibe, and then finally going in. So we achieve targets very easily. And the safety, again, needless to say. And finally, the 10th point, Lipid Association of India clearly endorses that if the patient is having acute coronary syndrome, you should not be wasting time. Right at the discharge, please add patients maximum rosuvastatin, maximum atorvastatin, either maximum rosu or atorva plus ezetimibe. Look at 4 weeks, what happens to this patient. Still LDL is more than 55, don't waste time. At 4 to 6 weeks, start giving these patients PCSK9 inhibitors, be it inclisiran, be it evolocumab, and bring things within the target by 12 months. So with this, thank you so much for the patient hearing. Yeah, thank you.
Thank you, Dilip. Please join. I think I'm very impressed by the efficacy of this molecule. We are part of some of the trials before, and once we started coming and we used in many patients, and you have seen incredibly low levels of LDL, like 17, 19 LDLs, which are not there in high-dose statin therapy before, are possible with this new molecule with the benefit of no side effects and making it once in 6 months injection. Actually, if you believe a concept of cholesterol leading to disease, I think it's a great opportunity for all of us. The recommendations could come later. As of now, it is recommended only in actually familial hyperlipidemias, where in spite of all things are very high. But the amount of significance of reduction is documented very clearly. And once LDL cholesterol goes down below 40, the regression of plaques is noted. I think that data is very clear with the previous high-dose statin with combination therapy. But when you can achieve that with once in 6 months shot, there's nothing like it. I think if the safety concerns are not there, I think all of us should utilize this chance. I feel all the doctors, cardiologists, physicians who are stressed up with day-to-day practice, our mortality patterns are quite high. Many of them suffer this problem. I think if you have the concept of total cholesterol exposure reduction, that is what is proposed by Brownwald. If you do it from early age, probably you will never go into the level where you get into coronary artery disease. And you have a chance now to leave coronary artery disease free for 100 years. It's up to us whether you want to utilize the money which you earned little for your health, or to go to Dubai or some shopping, or all that is okay. So, but it is absolutely essential for us to realize there is a very potent and effective molecule which has come into the market, and then it's up to us to decide and use it accordingly. In all my high-risk CHIP patients who have LDL cholesterol more than 70, we started using it. Actually, in pre-discharge also we give in some patients, and some of the insurance companies also started covering this. But one thing I wanted to mention clearly is those patients, anyway it has to be used. There's no choice, no chance, anyway it will be used. But for professionals, I feel, or for people who are affluent, who can take it, I think you have an effective solution which is actually could work as a vaccine for coronary artery disease. I got into more and more confidence because when I went into that ad board meeting in Dubai, I had interacted with a doctor who has used this for 700 patients. In Dubai and Abu Dhabi, everything is covered free for them. I interacted with that 700 patients were treated with this. None of the patients had any side effects. On the other hand, many of them had significantly low LDL cholesterol. Whether it is turning out to be decrease in heart rates, decrease in mortality, that the data will come in next year once Orient data comes follow-up. But before that also, I think if anybody wants to reduce your cholesterol levels, here's an opportunity to take once in 6 months shot and be protected from these cholesterol mal effects. Only one word of caution is, in India, we do find some patients where triglycerides are also a little high. This molecule doesn't act that strongly. But if you strongly believe in LDL cholesterol and total cholesterol, this is the molecule to reckon with, and all of you to take this molecule seriously. In future, if triglycerides are high, the ANGPLAT receptor blocker is also likely to come. And such RNA-based mechanisms are here to stay. And the antihypertensive therapy once in 6 months also have started. Why I'm telling all this is, these are proven, quite safe methods of long-term efficacy. And that molecule which has come into clinical practice, the benefit of it should be passed on to all our needy patients, and including we professionals who are exposed to high risk. If you have LDL cholesterols of more than 100, I feel definitely you will benefit. If it is more than 70 also, you could benefit. If you are averse to taking, many of the doctors are poor patients. I started collecting data with the doctors who get CT scans done. I show them the plaques inside. Still the doctors don't take medicines, including me also maybe. So this is an effective way where compliance is not a problem. Take once in 6 months shot and be done with it, and then probably you can remain free from coronary artery disease for 100 years. I talk it very passionately because in recent TCT meeting also, in the entry point, I put one side stent, other side inclisiran injection. So prevention and as well as intervention, both go in hand, and it goes a long way in preventing events. Even in our interventional meeting, I thought it is very apt because once you do high-risk intervention, patients should not get into trouble again and again. So it's very important. I am not saying this as a replacement for statin, don't get me wrong. Statin anyway is here to stay. Along with it, rather than going to strange drugs like other which are less proven, and then probably you can take the help of this molecule. And Victorian Initiate has already proven that and shown that it is very effective. So this I request our senior colleagues here to pass few comments for the benefit of others, and then we can close.
I think what was impressive in the data, especially with the South Asian and Indian context, is reduction in LP(a). So LP(a), ApoB, all these things are also being affected. More important than triglycerides, I think reduction in LP(a) will have a tremendous. Statins were not doing much to that element of lipids.
Nothing, they were not effective at all. Now you have 27% reduction of LP(a) also. So that is another reason. Those are indications anyway you have to use it. I am saying even if other things are normal, if you believe in this concept of cholesterol is equivalent to high risk, I think you have a chance to reduce it.
Yeah, it's like a vaccine, yeah.
Whether statins can elevate the levels of LPA. There are some studies.
Now, as of now, there is no approved treatment for LP(a), but this drug significantly reduces LP(a). And in Indian settings, I think LP-Little is probably a neglected entity. Still have a lot of high LPA. And this is an ideal drug for a statin intolerant patients. I'm sure all of you have some patients who cannot tolerate statin, or maybe tolerate 5 to 10 milligram of rosuvastatin. There you will never be able to achieve target. And as rightly said, we are doing complex interventions. We don't want him to come back to cath lab again. If you want to prevent death or cardiovascular mess, it is better that you aggressively control lipid, and that cannot be controlled only by giving statin or ezetimibe. You might have to add something more. And if you go by the Lipid Association of India guidelines, extremely high risk patients, now they are divided into 3 categories. And in the 3rd category, they suggest that you should bring it down by less than 30. Less than 30 LDL, you will never be able to achieve with bempedoic acid, ezetimibe, and statin combination. You have to use this.
Dan, sir, your comments on this? You want to say anything?
I endorse the last statement that if you really want your LDL to be so down, I think rest of the drugs really cannot do it. And I quite appreciate your concern that a lot of us are busy in just stenting and without really bothering about prevention. I think today you have a molecule which can give you very good protection, and especially in high risk cases, there you can easily spend. But I think why high risk? We are all high risk. A lot of us have family history. A lot of us have lipids which are not very good. And as you rightly said, rather than spending your money on holidays, spend it on yourselves. And if you are healthy, every day is a holiday for you.
Thank
you. No, not holiday, sir. Rather than spending money on future stent.
Yeah.
Thank you. Any other comments or questions?
As far as LP is concerned, I think small queries there.
I think anybody in the hall has any doubts, anything on lipid therapy or anything before we close? I think tomorrow we'll reassemble back at 9 a.m. and probably you'll have more discussions on CTO, which many people want to learn, and structural heart interventions, TAVR, and other things coming up. And the newer interventions also we have pre-lunch. I think there are no further questions. I'll hand over the mic to you.
So before ending the session, I could request Mrs. Sandeep Sharma to felicitate Dr. Manish Kapoor, sir. I could also request Mr. Sandeep Sharma to facilitate Dr. Manish Kapoor, sir. Okay. Dr. Vijay Trechen, sir. Vijay, sir. Now I could request Mr. Anirban Chatterjee to facilitate Dr. Sundeep Mishra, sir. Okay, he's not available. So next I could request Dr. Rahul Chakrabarti to facilitate Dr. Rajashekar, sir. I request Mr. Krishna Rao to facilitate Dr. Riddhi Siddhi, sir. Next Next, I request Mr. Anirban Chatterjee to facilitate Dr. Bhupan Desai, sir.
Thank you, everyone. Please requesting everyone to be here by 9 tomorrow morning. Breakfast will be between 9 to 8:45, and it is at Frago. 7 to 8:45, and that is at Frago. So now you can join us for the dinner and cocktail. Yeah. Thank you very much, everyone.